okay? So again, to make sure that you get the maximum therapeutic benefit with the minimal toxic effects. Because you know everything has a side effect, right? So we want to make sure we don't kill you trying to kill something else. Okay, and then there's just some definitions there for you. Nothing too big. So again, with therapeutic drug monitoring, we worry about liberation, and that's the release of the active ingredient. So as we're talking through some of the medications, there are some medications that you have the parent drug, and then when it breaks down to, it has a metabolite. Okay, sometimes the metabolite is as effective as the parent drug, sometimes it's an inactive ingredient. And you know this, because you read about the bottle about everything you take, right? And it tells you active ingredient, what it is and the percentage, and it'll say inactive ingredients. Okay, but sometimes with some drugs, both of them are active, okay? Absorption is the route of admission. You know that some drugs you can take by mouth, right? You know there's some drugs that you actually have to get an IV, right? I get an IV infusion every month, okay? And then there are some that you have to do by suppository, okay? So it all depends upon the route that we're giving it. And based on the route that we give it, we'll have different, not different, but quicker or better results, okay? So we call it a first pass elimination. You guys know when we talked about this, one of the functions of the liver was to detoxify, right? So not only is it going to detoxify the bad things, but does it know that a drug that we're giving you for as an antibiotic to kill something, is that any different than the alcohol you drank the night before at a party, right? No, your liver doesn't know the difference. So in order for a drug to be orally effective, 70% of that drug has to still be available if you take it orally. In other words, the first pass elimination, the first time it goes through the liver, 70% of that drug still has to be effective. If 70% of it is not effective, if your liver pulls out too much, then we have to give it by a different route. So again, IV or suppository or IM. Okay, you can't take it by mouth because then the liver will take too much out. Okay. Bioavailability is the extent of the absorption, and again, availability for a distribution. So 70% has to still be available to be orally effective. So everything goes through a clinical trial. Everything goes through a clinical trial. You know, you wonder why drugs are as expensive as they are, or why a manufacturer wants to patent it, because he wants to get as much money as he can before it becomes a generic, okay? But again, you have to think about all the money it's taking him to get that drug out there, with all the clinical trials they have to go through and the process of making the drug and everything else. It's almost, if you took that away from him, what would be the purpose of making a drug, right? If there's no monetary reward. And when we get to PCR, we'll talk a little bit more about that, because there are so many things that we could do by PCR to identify, but again, if it's not an advantage monetarily, they won't do it. So we'll talk about that when we get there. Okay, so first pass elimination again is when it goes through the liver, and then bioavailability is the extent to which it's available after it goes through the liver to be orally effective. Distribution. Distribution is the process of the drug either binding to receptors, passing through tissue membranes, cell membranes, things like that, protein binding. Some are fat soluble, some are not. So the distribution of a drug can take anywhere from 30 minutes to 120 minutes, okay? This is important to know if you're doing therapeutic drug monitoring. Because if the distribution is at 30 minutes, you would want to draw your peak level at 30 minutes, versus 120 minutes, you would want to wait till 120 minutes. You have to realize this is not your job in the lab. It's not your job to know what drug they're giving, when to draw that peak level. And if the nurse calls down and says, hey, when am I supposed to order the peak level on this vancomycin, you have to tell them you need to go to your nursing SOP. It's their job to know what it is they're giving them and how they're giving it to them to order the peak draw, okay? It really is. It's their responsibility.
Yeah, they call all the time. What do we draw? How do you draw this? What test do I order? Would you ask the doctor that?
Yeah.
Like,
and again, we're not supposed to tell them Again, that's baiting. We're not supposed to tell them. Unless it's just simply a nomenclature kind of thing where they're just not sure of the name or something like that, you can tell them, but you can't. Like if they say, do I want the one by PCR or do I want the one by immunoassay? That's the doctor's decision. That's something we can't say.
Yesterday. I'm like, we need to ask the doctor that
Yeah.
give out that one.
Yeah, so again, but again with distribution, they're gonna order peaks and troughs, which we'll talk about in just a second, but again, a trough we know because that's before the dose, and then the peak again would have to be determined by them based on what it is that they're giving them and how they're giving it to them, okay? And they get messed up a lot.
So when a medicine's saying rapid release and they're gonna say it's gonna work within 15 minutes or something like that, is that false advertising?
Not necessarily, it may start working within 15 minutes, but the peak level may not be until a certain time. And we don't obviously do therapeutic drug monitoring absolutely everything, but there are some drugs, and we'll go through which ones we do, okay? Metabolism, again, that's the biotransformation of the drug from the parent drug to its metabolite, again, splitting it apart. Parent drug is the active, metabolite can either be inactive or active, okay? And then the last part is excretion, how does your body get rid of it? And this is important to know. If you're taking a drug, and again, every drug has toxic effects as well as therapeutic, you need to know how is this excreted. And if it's really important, the doctor's gonna ask you, have you ever had kidney problems, or have you ever had this, or have you ever had that? And they'll test things like your liver, have you had liver failure, or you have, elevated liver enzymes, because if it's cleared, or not cleared, it'll make a difference. If it's renal and your kidneys aren't filtering, what's gonna happen to your drug level? It's gonna increase. You're gonna get too much of the drug, right? Okay. Rectal, what if you're constipated? If it's passed through your stool and you aren't passing stool, what happens to your level? Increase, exactly. Through your sweat. Have you ever taken anything that after you've taken it, you can actually smell it on your skin? It comes out your sweat? No? Oh, you guys are healthy. Okay. Saliva, again, probably taking the stuff a little while later, like, oh, why do I have this horrible taste in my mouth? Okay. And then some of it is just by how you exhale it. So if you have emphysema and you're not breathing well, does that make a difference? Of course. You have to be able to eliminate it. Okay. So again, therapeutic drug monitoring. We got to make sure that your peak isn't too high because we don't want to kill you. We want to make you better, right? So how are you getting rid of it? Excretion. So pharmacokinetics is just how the drug is metabolized and used in the body. Let's get more definitions for you. Kinetic elimination, first order is what we said we used for enzymes. Zero order, there's a constant amount per unit of time that's independent of the drug. So for our drug monitoring in the lab, we do zero order, which is again, amount of time independent of the drug concentration. So that's what we do as far as what in lab testing. Volume of distribution is the volume of fluid to dissolve the total drug. We also have to worry about a half-life. We probably think of half-lives more in like radiation, things like that. So if I give a person 100 micrograms of a drug, and if the level drops by half in a certain amount of time, I know how long it's going to take for that drug to be out of your system. And this is how you've taken medication, right? Some of it says take every 8 hours. Some of it takes every 12 hours. Maybe you only take it every 24 hours. So again, how do they know how much that drug is going to drop its level? If I give it to you every 8 hours and it's really not going to drop by half until 24, you're going to be overdosed, right? So that's why it's important to take it when it says to take it. Slow release versus long release, the fast, quick release for your headache, right? You have the ones that are all broken up. You ever cracked open one of those capsules and everything's in little pieces, right? Because it's fast release. You would just say, works quick, 15 minutes. And then there are some that are slow release, and that's because the pill is, and it have you ever taken one that says do not crush, do not break, do not bite, do not chew?
Mhm.
Again, because they don't want it to get, to your system that fast. It's slow release, okay? So if I give you a drug, and again, if I give you a drug of 100, whatever unit, microliters, whatever, and the half-life is 2 days, how long is it gonna take you to get rid of that drug out of your system?
24 hours.
Okay, so in 2 days, right, you're gonna be at 50%, correct? Right? 2 more days, you're gonna be at 25%, right? 2 more days, you're gonna be at what?
About 16 to 20.
Right? 2 more days, you're gonna be at what? 2 more days, you're gonna be at what?
312.
So again, going and going and going. You get it? Okay. So I'm gonna give you a number, and I'm gonna give you what your half-life is. And you're going to tell me how many days it's going to get to, how many days it's gonna take to get to a certain level. Okay? Would you be able to figure that out? And I don't make math hard otherwise. Steady state. Steady state, again, your peak, let's go a little slower. So your peak is the highest level in your blood that you have, that when you take that drug, at what point is it gonna be at its highest level, the peak, okay? Again, 30 minutes, 60 minutes, 120 minutes, whatever it is for that drug. You don't determine that, the nurse determines that, okay? Trough is the lowest level just before dosing. So in the lab, they order a trough 30 minutes before the next dose. So it's a timed draw. So they'll say you need to come up and draw this theophylline at 7:30, knowing that at 8 o'clock they're gonna give the next dose, okay? Your trough can be drawn from 30 minutes right up to, you can be standing there drawing the blood when the nurse is getting ready to hang that unit or give the patient that pill, okay? If you walk into the room and she just gave the medication, what do you do then?
Wait.
They have to reorder it, okay? Because you can't do it, even if they just popped the pill in their mouth, swallowed it, you can't, okay? Has to be done before the next dose. And this happens because, she wanted to go get a cup of coffee, so she just decided she'd hang it just a few minutes early. Okay, so then you have to reorder it and do it around the next dose, okay? MTC, minimum toxic concentration, MEC, maximum effective concentration. So you basically want to stay between those, right? We don't want to be toxic, but we want to be effective. Make sense? We want to stay in there. So it usually takes 5 to 7 doses to reach a steady state, where the peak and the trough lie within the therapeutic range, again, between the MEC and the MTC. So I have a picture on the next slide. So you give the dose. So what is your level on day 1 when you just fill the prescription? 0, right? 0. So this is when you get the prescription filled. You take your first dose and you peak, right? And then you're gonna drop back down, but your level's not gonna go back to 0 because it says to take it every 8 hours, right? So at 8 hours, you're taking it again. You still have drug in your system, correct? So you're not dropping back down to 0. So you take your second dose, and it takes you a little bit higher because you have some in your system. So you're not going from 0 to 10, you're going from 2 to 12, right? Okay? Take your next dose, same thing. So again, after about 5 to 7 doses, what you're going to see is your peaks are all the same and your troughs are all the same. Okay, so you're in that level between toxic and therapeutic. So again, 5 to 7 doses. Make sense? So again, take your medicine on time and keep taking your medication till all of it's gone, just like they say. So factors that affect drug disposition, again, your age. If you're pregnant, so why pregnant? Because they have a liver too, right? And so yes, they're clearing it too. So again, diseases, hepatic, you got liver disease, not gonna clear it as well. Cardiac, again, renal, if you eliminate it through your renal and you're having renal problems, you're not gonna eliminate the drug, okay? Again, the metabolite, what does it break down to? Again, is it water soluble? Is it easily excreted? Sometimes they have a longer half-life than the parent drug, so they stay in your system longer than the actual parent drug. And again, they can produce either therapeutic or toxic effects. So again, sometimes you have to monitor not only the parent drug, but you also have to monitor the metabolite. Okay? And again, it might just be inactive. And when we actually start talking about drugs, we'll talk a little bit more about what their metabolites are. So what makes TDMs easy, or what makes this test one of the easiest ones, there are no normal values, right? If you don't have a headache, you don't take acetaminophen, right? So you have 0. So there are no normal values. They're what we call therapeutic ranges. Okay, if we're gonna give you a drug, there's a therapeutic range. Again, minimum toxicity and maximum effectiveness, okay? So if my therapeutic range, so on the test I have to give you a therapeutic range because there are no normal values. So let's say I'm giving you theophylline, okay? And the therapeutic range is 2 to 15, let's say, okay? Milligrams per deciliter. So if I am sub-therapeutic, what is my value? If this is the range that I want to be in so that I'm getting some relief with my theophylline, which is a bronchodilator, if I am sub-therapeutic, what does that mean? Less than 2. So if my value is less than 2, when I do my therapeutic drug monitoring, I draw the patient's blood, and I get a value less than 2, is the drug helping them at all? No. No. Okay. Therapeutic, again, the range in which the drug has the minimum toxicity with the maximum effectiveness. Okay. Toxic. Toxic does not necessarily just mean greater than 15. A toxic value is usually greater than that, okay? And every drug has its own toxic value. So again, this isn't something you have to memorize, okay? But if my top level is 15 and I'm getting 35, can you pretty much think that there's a problem? Okay, so usually if it's significant. Some drugs more than others. We did some drug testing on a patient. It was actually for a gentamicin, which is a gram-negative antibiotic. And the doctor actually wanted 3. He wanted a trough, and he wanted a mid, and then he wanted a peak. Wow, now he's on sure what he did. So my trough, so let's say therapeutic was 2 to 20, we'll say. So my trough, let's say was 2. My midpoint was 0, and my peak was 18. Think I had a problem?
How did your midpoint drop?
I'm sorry?
How did your midpoint drop?
Exactly. Exactly. Okay. Now, if I was at 2 on my trough, going to 0 at my midpoint, I'd think, okay, they just forgot to give the drug. The nurse just didn't give it. So I didn't freak out too bad, right? But then when I got 18 for a peak, I'm thinking, well, wait a minute, he did get the drug. So actually I took, and I wasn't the phlebotomist, somebody else was. I actually took the specimens to blood bank, and I did a blood type on the patient. And this one and this one were the same, but that was a different blood type. So they drew the wrong person. Okay? So again, if you know, so let's say, if it had been the right person, let's say this number should have been 10, right? But you know that if you get in a value at a trough and you're getting a value at a peak, you can't have zero in between. So that's what you kind of got to think. So are my results making sense to me? Okay. So of course we did a credit for this one, and then they just ended up doing it again on the patient in the next dose. Because the phlebotomist, and I don't know who they drew, but it was obviously the wrong person. Okay. So again, thinking about what my results should be needs to kick into your head as far as something's not right here. Okay. So factors that affect your therapeutic states, again, the time of drug dosing. Did they give it too early? Okay. Duration of the drug therapy, how long have they been on it? Again, it's going to get into your tissues, it's going to get into everything. Peaks are going to be a little higher. Time of blood collection, that is probably our number one problem. And it's not because our phlebotomists are going up when they're said to go up, it's that the nurses a lot of times don't give the drug when they were supposed to. And I mean, a little bit of both, but more times than not the other way around, isn't it? Okay. The pharmacokinetics of the drug, again, what's it breaking down to? What is it actually doing? So again, pharmacology or the activity of the metabolite. And again, protein binding with the drug. Some require it to be bound to a protein, some don't. Okay. And the presence of disease. We talked about that. Liver disease, kidney disease, heart disease. What's wrong with that patient if they're not clearing it as well as they could? Just some laboratory analysis, again, reflects the free drug plus the protein-bound drug concentration, and those are just some methods that you can use. It is important to know that the specimen of choice is serum, not drawn in an SST. So a plain red top, okay? Why would you want to do an SST? It's a serum separator tube, and we want the serum, but they've actually done studies. So what happens to that gel when you put it in the centrifuge?
Separate.
It migrates through the blood, right? It separates out the serum from the cells. They've actually done studies where that gel, as it's migrating through the specimen, will absorb the drug. And so levels were lower on SST tubes versus plain red. Okay, because again, the gel will absorb the serum, or absorb the drug. So again, if it says plain red, draw it in a plain red. Don't think you can get through an SST. Okay, it has had problems. Okay, so some drugs that we do therapeutic drug monitoring on. Digitalis or digoxin, which is actually a plant, and you can actually, in some countries, they actually chew the plant and get their effects from that. But you know, it's a little more specific now. We don't just tell you to go out and throw a plant, eat it. But again, it's used to treat congestive heart failure. So again, to help the heart contractibility. All right. Toxicity. A lot of them are going to have the same toxic results: a nausea, rapid heartbeat, visual impairment. Sometimes it'll be nausea, sometimes it'll be dizziness and things like that. So I wouldn't worry too much about toxicity unless that's really different and they tell you to know that. The half-life is in the absence of renal failure. So again, if you're having kidney problems, it's going to be a problem. Again, 35 hours, excreted in the urine. Peak concentration 8 to 10 hours, and that's when the drug is equal between the tissue and the serum. Okay, so again, we're going to want to draw it 8 to 10 hours after the drug is given. Okay, I don't know when they tell the patients to take this, but I know that our digoxins always seem to be drawn at 8:30 in the morning, regardless of who they are. So and when they're outpatient stuff, they're always like have to be there at 8:30. So I don't know when they tell them to take their drug, but that just must be something because I just know that they always are. Metabolized in the liver, which most of them are. But anyway, digoxin, so that's for congestive heart failure. It's a cardiac glycoside. I spell that if you want. So cardiac, glycoside. Quinidine is given for myocardial depressant, it's myocardial depressant, treats cardiac arrhythmias. This bromide, whatever, used as a quinidine substitute when quinidine isn't available. I actually threw this out at one time, but then it appeared back in your book, so they must be still giving it, but again, as a quinidine substitute. And you learn it, and if you, sometimes quinidine given with other drugs has a higher result and more than they want, and so they would give the other one instead. Lidocaine is used to treat ventricular arrhythmias. Usually lidocaines, they want stat. They have two active metabolites, and when the drug breaks in half, both of them are active, okay? Again, metabolized in the liver, half-life is 2 hours. And again, they're pretty much always run stat. I don't know that I've ever had one that's not run stat, and usually call the results to the doctor. I'm not exactly sure if this is the same kind of lidocaine that they give you as a numbing agent when you get your teeth. People ask me that all the time, and I can't really find out anything as far as if it's just processed differently or what it is, but anyway, lidocaine. Have you heard this on, you watch doctor shows at all? Giving them lidocaine for heart arrhythmia? No? Pay attention, they do. Procanamide. Procanamide is a drug that when it breaks apart, it has the parent drug and it has a metabolite NAPA. Because both of them are active, you actually have to run both at the same time. The doctor, it's kind of like your INR with your ProTime. When you order a ProTime, you automatically get an INR. If you order an INR, you're automatically going to get a ProTime. Same thing. If they order a procanamide, you might as well get the NAPA reagent right out of the fridge at the same time because you're going to give them both. Okay, same thing. If they order the NAPA, you're going to get the procanamide. Treat ventricular and atrial cardiac arrhythmias, tachycardia, which is fast heart rate. Yeah, fast heart rate. That's procanamide, and it's active in NAPA. Big word. On your test, what is NAPA? I don't give you the whole big word. So anti-epileptics or for anti-seizures. Alters the transmission of the nerve impulse within the brain to minimize seizures is basically what these drugs do. Phenobarb treats febrile seizures, generalized febrile seizures. Primidone is an inactive form that converts to phenobarb, so that's important to know. So a lot of times they'll order primidone as well as phenobarb. Toxic effects, confusion and irritability. For a long time, phenobarb was not given to outpatients. It was usually only an inpatient drug. The next one, phenytoin, was usually given as an outpatient drug. So when you had a patient, an outpatient, come for blood drug testing, and phenobarb, the initials are PHEN, phenytoin, the initials are PYT, okay? So again, you need to pay attention what you're looking for, and so a lot of times they would order the wrong drug, and because you knew whether they were an outpatient or an inpatient, you kind of had an idea. If a phenobarb came across and was an outpatient, you could go, whoa, wait a minute, I think you guys ordered the wrong one. But it's my understanding now that they're giving phenobarb even to patients as outpatients, so it's not as easy cut and dry to make sure they've ordered the right one. A lot of times it gets confused in the ER as well, so again, those two are kind of easy to get confused just again because of the abbreviations on the reagent and the abbreviations when the doctor orders the test. Okay. Again, for seizures, depresses the central nervous system. So again, anti-seizure, anti-epileptic. They put my dad on phenytoin when he had a brain tumor, and he said he just always felt like he was walking around in a fog. So I don't know, I mean, I've heard other people say that too, that this kind of alters their thinking and they don't seem to be as sharp as they were. But if it keeps you from having seizures, I guess that's better than having seizures, but they do feel like they're in a fog. That's just a comment I've heard from patients. Again, anticonvulsants, valproic acid, also known as Depakote. And again, you'll get the order for either valproic acid or you'll get it for Depakote. one or the other, so you need to know which one's which. Okay, well, it's actually the same thing, but you'll see it both ways. So on your test, when I have two drugs with two different names, again, they may order one or the other. That's basically a matching on your test to be able to match up the two different names for the same drug. So petit mal or absent seizures, an absent seizure is where they come out of their seizure and they don't remember what happened. So the time that they had the seizure, they don't remember what happened, okay? With valproic acid and with carbamazepine, if you're taking two different drugs for the same problem, okay, the levels will be different. So there are no, again, normal values or even therapeutic values. So again, you're gonna get a call from the ER physician and go, hey, you didn't give me the therapeutic for carbamazepine. Well, we can't give you a therapeutic range because we don't know what other drugs the patient is on. So again, they have something in the emergency room that tells them if they're on carbamazepine alone, their therapeutic range is this. They're on carbamazepine with valproic acid, their therapeutic range is this, or if they're on such and such. So again, that's something that's in their SOP. They need to check for that. We don't keep those levels in laboratory. Again, carbamazepine and Tegretol, two different names for the same. And these are just some second generation drugs that are out there. I've not seen so much drug monitoring on these. I think they are a little bit different. At least we don't do them in the lab that I know of. These are probably ones that if the doctor was specific about, he would probably order it as a send out. But again, these are second generation ones, not the ones that we're that familiar with. Bronchodilators. So if anybody here have asthma? Do ya? You take a bronchodilator, you inhale it, one of those inhaler thingies. Do you get blood monitoring for that? No. But theophylline is one that we usually give patients as a bronchodilator. A lot of times when they come into the emergency room and they're having a bad asthma attack and they can't breathe, theophylline would be something that they would put in one of those little atomizers or whatever and get them to breathe in. We do have to do therapeutic drug monitoring on theophylline, so we do need to know peaks and troughs, so we don't give them too much. Again, used to treat asthma. We had a little boy come into the emergency room, this was a couple years ago, and I think it was the worst asthma attack I had ever seen. When he tried to breathe in, I mean, his chest just really caved in bad. And I can only imagine not being able to breathe and feeling like you're just almost drowning, right? I mean, I guess you just can't get your air in. Has it been real bad for you, or does some certain things trigger it for you, or?
Mine is in remission for a couple years now. But
So-
when I was a kid, I had to have the nebulizer like around the clock. My mom would have to get up in the middle of the night to even
Oh,
treat it,
really?
so it was that bad.
Wow. But it's gotten better? Have they done anything to make it better? I mean, or did you just kind of outgrow it? Well, that's kind of cool.
The only time I ever have problems now is like if my allergies get really bad.
I was gonna say, are you allergic to a lot of things?
Seasons.
Yeah.
That's me too, allergic.
Because I know my daughter had a friend who, like, her bedroom was the only one that didn't have carpeting or anything, because even the carpeting in the bedroom and stuff would just set her off and things, and then her dad brought home a dog, and, yeah, she went crazy. But, yeah, I imagine it's a scary thing. It is important to know that there is a metabolite, caffeine, when you give a patient theophylline, okay? So if we're giving an infant or a neonate theophylline to help them breathe, we need to know that, again, caffeine is an active metabolite. And so what happens when you drink caffeine? Heart rate starts to go a little faster and it kind of wakes you up, right? So again, if this is a neonate, something we need to be careful with. So we need to monitor the neonate. I've heard people who have asthma say that it is better when they drink a caffeinated soda. Never noticed? No? I've just had, when I usually, but I've been told by several students that that was actually a question on their registry. I'm like, okay, well, it was in your notes, so we covered it. But again, something that a lot of them don't remember, that caffeine is a metabolite of theophylline, so we need to measure it in babies. Psychoactive drugs, so these are things that are going to, like antidepressants or things that are gonna help with your mental capacity. Lithium is to control manic depressive disorders. It is in a capsule, it's a powder. A couple years ago, we had a lady that worked in a daycare in Belleville, and she had lithium capsules in her purse. And I guess she left it where the little kids could get to it. And before they knew it, then the little kids were playing in this white powder all over the table. And so the emergency room got inundated with about 20 little 2 to 4 year olds, and they had to draw lithium levels on all of them to see whether or not they had ingested any of the lithium. Luckily, all of them were negative, or at least low enough to where it didn't register. I don't think she works there anymore, but anyway, so again, something you might end up getting in your laboratory. So lithium's where you wouldn't maybe get but 1 or 2 a day. Here we ended up getting 20 in 10 minutes. Long-term therapy can cause a goiter, which is your thyroid gets enlarged, okay? And or with or without hypothyroidism. So where their thyroid is affected. So that's a long-term therapy problem. Psychoactive drugs, your tricyclic antidepressants, TCA. We do TCA testing in the laboratory. TCA is one that they worry about if you come to the emergency room, say in a car accident or something like that, because if you are on TCA, it can cause certain anesthetics not to work. And I've heard story, I've never seen it in a textbook, but people who have been on TCA and have been put under for like surgery or something, that they were under enough to where they couldn't yell, scream, or talk, but were alert enough to know what was going on in the room. So again, I don't know if that's just a, what do they call them, urban myth or whatever, but as you know, we do a lot of TCA testing, and I have some kits in there if y'all want to do that. So we will do some drug testing, and you don't have to use your own specimen if you don't want to. And then lorazepam for schizophrenia, bipolar schizophrenia. TCA is probably the one to measure the most. Antibiotics. There are some bugs that don't respond to just oral antibiotics, so we have to give it by IV. The toxic effect of these antibiotics are permanent hearing loss. So we have to do therapeutic monitoring, your peaks and your troughs, for these antibiotics. They are for gram-negative aerobic bacteria. And you know, you've heard this over and over again, the superbugs, right? The bacteria that nothing is killing, because we've overprescribed antibiotics, and so these bugs are getting really good. So these antibiotics are very, very expensive, and but again, it's when nothing else will work, we're going to give you an IV antibiotic. But again, can cause permanent hearing loss, so we want to make sure that you aren't toxic. And they are amikacin, gentamicin, tobramycin, vancomycin. So we do therapeutic drug monitoring on those, all of those. And you were asking earlier about probiotics, and these would be one of those drugs that would kill your gut bacteria. And so that's the study was actually when you give a patient these kind of drugs. When you give them a drug like this, it will kill what's in your GI tract, and before you know it, you've got C. diff or something really bad. And so that's when they do the stool transplant of a family member or something like that. And she was asking me earlier about a probiotic, and my doctor was actually telling me about a study that she was a teacher doctor at this facility, and the students had to do, you know, like how Jean and I have you do little projects or whatever, your studies, whatever. They had to do one, and the students chose to do one on, if you give a patient probiotics while you're giving them an antibiotic that would kill their gut bacteria, they actually found that it was therapeutic. It was actually helpful to give a probiotic for good bacteria, and then their incidence of getting C. diff or a yeast infection or something bad was much less by doing that. And so it's just a neat study we talked about. Anti-inflammatory painkillers, these are the ones I'm sure you're familiar with. Your salicylate, so what's another name for salicylate? Aspirin, yes, aspirin. And does anybody really take aspirin anymore? I mean, I know I take it, but that's for platelets, not for,
I take baby aspirin
for platelets or for,
to keep my preeclampsia from coming back during my pregnancy.
okay, so it's for therapy.
And my mom takes it.
But back in the day, you know, you had a headache, you'd take aspirin, but I
My
don't
mom
think anybody
takes
does
it.
it.
For, I'm not exactly sure what she takes. I think it's her blood pressure she takes it.
Yeah, I have blood clot in my left leg, so I have to take it for platelets, but. So again, toxic effects, again, take too much aspirin, again, because it affects your platelets and makes your platelets less sticky. You can have bleeding problems. ASA, again, is just another acetaminophen or salicylate type drug. Again, not using it very much either. Acetaminophen, which you know as Tylenol, which is the brand name, okay? Acetaminophen can cause all kinds of problems, but if you overdose, you can die. And this is the one that I think, were you the one saying that your doctor said this is not how, who was telling me that this, yeah, that this is not what you want to do to kill yourself?
Well, actually, he said that if you want to kill yourself, that's what you should do. Not overdose on any other drug, but if you want to die, the patient should
Oh,
die.
okay,
Because
okay.
there's no way to save you.
Okay, because yeah, once your liver's dead, you're done. So again, for the first 24 hours, nausea, vomiting. 24 to 48 hours, again, your liver's going to start dying. Your liver enzymes are going to start peaking. Okay, and your ammonia is going to increase. And then 3 to 5 days, again, hepatic failure and death. So again, not one of the things you want to do. There is an antidote for acetaminophen. How effective it is, I'm not exactly sure, but there is an antidote for that. And then Darvon, again, is a drug that we give patients, again, for pain relief. Anybody have Darvon? That's a pretty good one. There's a lot, yeah. Okay, so those are therapeutic drugs. We're gonna give it to you to help you. Now we're gonna talk about toxic drugs. You have to realize when we do a therapeutic drug, we have a therapeutic range. I said 2 to 20. With toxic drugs, there is no reference range. There is no therapeutic range. Okay. If you did not drink alcohol, your blood level would be 0, right? So normal, if you will, is 0. So your reference range is 0. So ethanol, what's ethanol? Okay, it is the most commonly encountered toxic substance in the emergency room. Gee, imagine that. You get more drunk people than anything. Acts on the central nervous system, can act as a depressant. A lot of people go to sleep, right, after they drink. It is important to remember, a lot of that just makes sense. If you were in the lab and you are drawing blood on a patient for an alcohol level, it's important to remember that you don't use an alcohol wipe, okay? The only time I've been hauled into court was before a blood alcohol. And I wasn't the phlebotomist, but I do know that they asked the phlebotomist, did you use the right wipe? Because you know how they have the Castile soap pads, which is like a little soap and water pad. They're in little packets just like your alcohol, but it's Castile soap, which is just a little soap and water pad. You don't want to use an alcohol pad. We, back in the day, now this is many, many years ago, we actually, as a control, okay, positive control, we had Everclear in our storeroom, okay? And so, yes, we had Everclear. And so as a positive control for our breathalyzer, okay, we would have a poor guinea pig that would offer to be our positive control. We actually took and squeezed the alcohol from an alcohol pad and drew blood through the puddle of alcohol on the patient's arm and still got nothing, okay? We've done the Everclear where we actually put a puddle on the patient's arm, stung like mad from what I understand, and drew blood and again wasn't effective. So it's really just kind of a way for them to throw it out of court, in all honesty. have I told you about that court date? I think I did, yeah, that's the most nerve-wracking thing I've ever done in my life. But again, you don't want to. And do you, as a phlebotomist, have to put something in the computer saying that you use Castile soap? I know we used to have to, I don't know if we do anymore.
No, we don't have to. It's funny because they've said that you can use core prep, which is 70% alcohol, just like an
Is
alcohol
it?
pad. But I know that we're, supposed to use it's just the same wipe that you use for a UA, Castile wipe.
Right, yeah, Castile soap, yeah. My daughter is actually allergic to alcohol, rubbing alcohol. And so, and we found that out when she was a baby, because they would use an alcohol pad to give her shots and stuff. And so I had her totally convinced until, I don't know, I think she was about 22, that she couldn't drink because she was allergic. Now, she knew she was allergic because if alcohol was one of the first ingredients, like in a hairspray or anything like that, she would react to it. If it was like in 6, 7, or 8, it was low enough that it didn't. But if you used a hairspray that had a lot of, literally every little drop that hit her from the hairspray, she would get a little raised thing. So I had her totally convinced that she could not drink alcohol because it would kill her, or that she would have a bad reaction. Because she knew, hand sanitizer one time, she wasn't even thinking. And yeah, it was just horrible. She's a teacher now, special ed teacher, and one of her students got a fingernail that scraped her face. And so she went down to the nurse's office, and the nurse just immediately grabbed whatever it was that they normally clean with, because she's like, it's under her fingernail. You don't know what germs are under her fingernail, and cleaned her face before my daughter had realized what it was. And I mean, the next day her face was just like, Mom, is this something? Or I said, no, that's your alcohol allergy. But anyway, I finally let her know after she was 21. I think, like I said, almost 22. But she doesn't drink anyway, so. And now she's pregnant, so she can. I'm not saying she never did and didn't tell me at that age. But anyway. Let's see, anything else? If you are stopped for DUI, and I know you would never do this, do realize, they ask you to blow, right, in the little breathalyzer thing. And then if you come up positive, they make you wait like 15 minutes or something to blow again, because like if you use like a mouth spray or something, it will artificially cause it to be raised or whatever. And you have the right to refuse that, from what I understand. I don't know, maybe the law's changed now, and have your blood drawn instead. But I will tell you that the blood draws tend to be higher, so you probably want to just blow and take your consequences. So anyway, there was a thing a couple of years ago where police officers were going to have to draw blood at the scene, because if you think about it, you had to, if you refused the breathalyzer, they would have to take you somewhere, either a hospital or something, to have your blood drawn. And so again, the time between when they stopped you until they could get you somewhere, and then, getting somebody to draw your blood and all that, sometimes it would be an hour or more, right? So your blood level would drop. And so there was a push to have police officers trained on how to draw blood. And so it was interesting here, because we were like, are we gonna get, because we have a police academy here. So we were thinking, we're gonna get inundated with, they're gonna have to bring them all here, we're gonna have to teach them all how to draw blood. But what they ended up doing was just at the facility, or a certain facility, they'd have like one person that would be trained, so that one person would go do it. But in all honesty, they still bring them to us, so I don't think anything's really changed in that respect.
That just seems dangerous. I mean, the military had them learn how to do IVs, and then the idiots were sitting there putting alcohol straight into their system. I mean, why would you
What into
teach
their
anybody
system?
alcohol straight into their blood system? I mean, they stopped that because of the stupidity that was going on, and then they give.
Geez.
Why would you do that to anybody that's not a medical and doesn't realize? Like medical, we've got.
I mean,
our own
phlebotomy
idiots, but
technically is OJT, on-job training. Technically,
that's ridiculous.
yeah, so, anyway, so what is the legal range for alcohol? What can you legally have in your system?
0.8. Or no, wait.
0.08, right? I think that's what it is now, right? 0.08. So, if I were running blood in the laboratory and I got a value of 0.3.
Are they alive?
The highest I personally have ever seen is a 0.45. And yes, he was talking. But he was a frequent flyer, as we call them, right? And so again, the more you drink, the more you can drink, right? So again, you get used to it. So if I gave you a result on a patient of say 0.3, would you accept that result?
Well, it depends on the history of the person.
So in other words, you'd call it, right? And you'd ask the patient. And yes, with my 0.45, I was like, is this guy comatose or what's the deal? And they're like, oh, that's so-and-so. And I was like, okay, I know the name. Okay, so you do know your frequent flyers. So again, it would be one that you would call, but you wouldn't necessarily have to throw out the result.
At what level is alcohol poisoning?
Again, depends on the person. For me, who never drink, right, probably a 0.9 or 0.09 would probably kill me. But again, but somebody who drinks all the time, again, the highest I've ever seen is a 0.45. So, and they were drunk, obviously drunk, but they were talking. So, but we've had kids, young kids that have had a bash or something, and they'd be like at 0.2 and they are not doing well. So again, it all depends on the person, so it's hard to say. Methanol. We get methanol if you don't make alcohol correctly in your still. You will get methanol,
Isn't
okay?
that wood alcohol?
I'm sorry?
Isn't that wood alcohol?
I don't know what it is. I just know that if you don't make it correctly, you will get methanol. In the laboratory, we have methanol as a fixative for our reagents, okay? If you do drink methanol, okay, it would metabolize in your liver to formaldehyde and formic acid. And what is formaldehyde?
Poison.
What do they use formaldehyde for? What would you know of formaldehyde?
Embalming.
Embalming, yes. It's going to pickle you, okay? Then again, like, and formic acid. So, I was working in a stat lab in North Carolina, and they brought me a specimen that looked like Kool-Aid. It was a urine specimen, and it literally looked like Kool-Aid. And they wanted a urinalysis, so I ran it, and of course, the blood was like out the wazoo, right? Really dark blood. But there were no red cells when you looked at it under the microscope. They were all hemolyzed. And so I guess it was probably 20 minutes later, I got another urine that looked exactly like it, just looked like Kool-Aid. And so I said, well, wait a minute, I've just done this. And they're like, oh no, that's his buddy. Okay, so they were making moonshine, I guess, or whatever, and got methanol instead of ethanol, and it was causing them to have a hemolytic anemia. So their red blood cells were just rupturing. So that was interesting, to say the least, I guess. So be careful. My son-in-law makes his own beer, and I'm always nervous that he's not gonna get it right. Oh well, I can drink it, so. Isopropanol, it's metabolized to acetone. So do you want acetone in your blood? No, that's like fingernail polish remover, right? Ethylene glycol is antifreeze. There are people who will drink ethylene glycol to commit suicide, okay? A lot of times you hear about animals that will drink it in garages or whatever because apparently it does taste sweet. And so animals will drink it and kill your pet cat or your pet dog. Can cause renal failure, and it will form oxalate crystals in your kidneys, okay? The treatment is actually making them drunk, okay? So if you come into the ER with ethylene glycol poisoning, they are going to give you alcohol to drink, they're going to keep you drunk, and at the same time, they're gonna do hemodialysis to get the the alcohol. So, ethylene glycol out of your system. So we had a patient in our ICU, and so we were doing alcohol levels just to make sure that he was at whatever level that they needed to. Now, hemodialysis will also take the alcohol out of your system, so they had to be very careful with what they were administering when they were doing the hemodialysis, because what's the point of administering it if the hemodialysis is just gonna pull it straight out? So we had to do alcohol levels at the same time as they were monitoring how to do the hemodialysis. So that was really interesting. Fun stuff you get to do in your job. So again, toxic drugs, these are your drugs of abuse. So usually we do a urine drug screen, which is just really a lot like a pregnancy test. And again, we have some in the lab we can play with. So benzodiazepine is a tranquilizer. Barbiturates are a sedative. Read through, there's nothing really special there. Hallucinogens are things like your cannabinoids, which is also known as weed. Yes, cannabinoids or marijuana, okay. PCP, phenylcyclamine, that also a hallucinogen. So these people will, stand on the roof of a building and think they have a magic cape and they can fly, yes.
Is PCP acid?
Is it what?
Is that acid or is that LSD?
Oh, I don't know I don't know what's their street names, I'm sorry. I mean, some I knew, but I don't.
I'm just trying to associate them.
And you can look that up, I don't know. You don't know street names.
PCP is what gives them schizophrenic. It can give them into a schizophrenic break. Is that you don't know? Okay, never mind.
There's homework for you. You can educate me. Stimulants, amphetamines, cocaine, things that these are, I guess, your uppers, right? Is that what they call it? I guess they do know a little bit of street names, so your uppers. Again, to stimulate the central nervous system. I am on a very low dose of amphetamine to keep my MS fatigue away, but it doesn't come up positive in a drug screen. It's very, very low. Although they do tell me that you can possibly do too much, but I don't take too much. So anyway, those are your stimulants or your uppers.
Pseudoephedrine and ephedrine are legal amphetamines, correct?
I'm sorry.
Pseudoephedrine and ephedrine are
The
legal ones.
Are the illegal ones?
Legal. They're legal.
That's what was in.
Pseudoephedrine, I believe, is
Isn't that what's in the
nasal decongestion.
right, that people are making,
Well, yeah, it's still controlled.
is that
so
the
it's
one you
legal.
can't buy?
You can buy it.
Oh, you can buy it?
It's
You can only
controlled,
buy
but you have to
some.
sign for it.
Oh,
It's
so
an
much?
ingredient for an amphetamine.
So,
It's an
okay.
ingredient for meth, so
Walter
it's not
Payton's.
actually amphetamine.
Oh. So amphetamine is like meth and cocaine. It's
Yeah,
not.
it's not.
Pseudoephedrine is not an amphetamine.
It's one of the
It's an
parts of it.
ingredient.
Yeah.
Yeah, it's a part of it.
Breaking Bad taught me something.
What causes them to blow up?
Right. Huh?
What causes them to blow up? When, you hear of a Met house or something blowing up, what blows up?
Well, isn't it the,
Do they use
some
propane or
acid,
something?
well, what do they use battery acid and.
You're kidding.
No, for real.
Oh, yeah, did you know everything?
Acetone, battery
Very high
acid,
temperatures.
and,
That's what.
Ew.
So it's a
Not
gas
bad.
station.
bad. So-
Everything is poison that they put in,
Yeah.
and that's why the effects are so awful on people.
So it's just some kind of, catalyst.
Like, if I touch a battery, that's like exploded, I can feel it like instantly on my hand, like tingling, you know what I mean?
Yeah,
Like the powder,
yeah,
I-
you do.
I don't know, if you had a whole bunch of that, I imagine that would blow up. or
They say
something.
like a drop of water, so condensation can hit the pot of whatever it is that the chemicals and blow up.
I was always I always want to know, we found this Met house because it blew up. I'm thinking, what is it that's blowing
The house
up?
across the street blew up.
I was gonna
About
say,
house next door.
There's a lot of,
Right. 3 years ago, yeah, and the owner has not returned since then, so I'm guessing there was quite a bit in there.
Oh, you guys ought to get this lecture. I learned more from you guys. I didn't know that. Again, I'm not up on my street drugs.
I think they figured out how to make it in bottle though now,
yeah, and
instead of
soda
in a
bottle.
soda bottle. So I don't think
Are you
that probably is
serious?
explosive, I don't know.
But I mean, you
It
can't
is,
even
yeah.
get Sudafed anymore, right? I mean, or can you?
Well,
I
you
still
can
do
go to
that.
the pharmacy and
like show your
Do you have to have a
license.
prescription for it then? You
No,
can't
you
get
just
it?
have to have a driver's license and be over like 18.
They just document like how
I was
many.
gonna say, do they
So if you
want-
buy 3 at Walgreens and then go over and buy 3 at CVS across the street.
But I mean, I know that they were trying to get all the drug facilities tied into a major computer system, but then the, Big Brother is watching
Mhm.
problem came up.
There is some sort, because I know that like in our ER, we can tell if a patient has gone to O'Fallon, Walgreens and picked up like a painkiller, and then the doctor's giving them another painkiller. So there's some.
So there is
sort.
some tie-in somewhere.
Yeah, I don't think it's necessarily nationwide,
Right.
but there is some sort.
Probably just for narcotics.
It's for narcotics.
So it's still a Schedule 3 drug. You guys don't,
I don't know.
unless you work in pharmacy, probably Schedule 1, 2, and 3 are.
So your opiates, opium poppy, you know how many poppy seeds you'd have to eat to get your drug screen to come up positive?
But Elaine on Seinfeld.
Yeah, yeah. But again, you hear people say that all the time, well, my opiates come up positive. I had a poppy seed muffin for breakfast or whatever. But I mean, you gotta eat, like you said, like a pound of them. So it's a lot of, unless your entire muffin was made from poppy seeds, I don't think there's a problem. So again, your opiates are your morphines and your heroines and codeine. Oxycodone is also in that list. So again, reduce sleep, pain relief. Little poppy seeds. So a drug screen, a urine drug screen. Must be a new slide, and I don't have it. But anyway, urine drug screen. So the procedure for doing drug of abuse screen, did you guys all have yours yet? Have you had yours yet? You haven't had yours? It should be coming up, because usually it's about this time. Well,
I think she said in October.
I was gonna say, yeah, I think it is, a little soon, because I forgot chemistry is crunched up in the whole process of things. It would be close to the end of chemistry. And so at some point, Candace is gonna basically walk in and say, okay, here's your paper, and you have, I don't know, 48 hours to go get your drug screen. And I know that it's always a big ordeal, so that might be something you wanna look into now as far as where you can go to get it, because the students would have it, and then they would try to use their GPS to go find the place, and the place had either moved or their GPS wasn't updated or whatever, and then the trauma sets in, and then everybody's panicking. And you have to be, some of them you need appointments and some of them you don't, and so you might want to do a little research so that at that magical 48 hour, you're not totally panicking over where to get your drug screen.
Do they let you pick your place?
Is there anywhere in Illinois?
Yeah,
Yeah,
there's
they'll give you a list.
there's a quest on the website of Belleville. that
In
does
Copper
it.
Bend.
But it's after Copper Bend, like it's in that
John
little
Frank
strip.
Scott.
Yeah, it's in
There's
that little
a-
strip center across from, like diagonal across from the gas station next to the police, the fire department.
Okay.
There's a quest in
Right
there,
next to
they'll
the
do it.
It's some Quest downtown too, that's close by, it's a lot of them.
There's a Quest in Edwardsville too.
But I just know that some students have had problems with the timing, and some wanted appointments, and some you could just walk in, and I just know that students have had problems in the past. But as long as you know where one is, and whatever, you're good with it. My husband had to have one for a job. This was a couple of years ago, and he went to one Quest, and it got all messed up, and yes, ma'am.
Are we gonna do the drug testing again for our spring semester?
You only do it once.
Okay. So we're not gonna have to worry about getting.
Now, I'm not saying that if you get hired, you're not gonna have it again. I mean, they're not gonna use the one you got for your school. I mean, we actually have had a student that tested negative in school, but then tested positive for his interview. I guess he partied for graduation, so that wasn't good. So he didn't get hired. I don't know the story since then. I don't know if he's working now. This was a lot of years ago, so do be careful. But anyway, he went to one Quest, and it totally got messed up between the order and what they were supposed to do, and they because there are different ones. You can have like a 9 to 5, or you can have, there are different ones depending upon what they order, and it really got all messed up. And so then they redid it, they resubmitted it, and explained, the job was okay with it and stuff. And he's like, well, I'm gonna go to a different one. I'm like, oh no, buddy, you need to go back to the same one, because now they know, and it will be done right. I said, you could go to another one, and it could get all messed up again if they don't understand what this particular business wanted. Back in the day, when we did legals at the hospital, each employer would have a certain one that they wanted and would want it to go to a certain lab. So you had to know who the employer was. So you had a big book and you would flip through and find out, okay, you work for Ameren or whatever. Ameren wants a NIDA 5 split specimen or whatever. Where a split specimen means half goes to one lab and half goes to another lab. So you basically have 2 labs doing it, because if it goes to one lab and it comes up, the patient can ask for it to be sent to another lab. So this way it's just done twice automatically, so we can find out right away. So different employers had different ones. And so I told them, I said, oh, if it just gets screwed up again, you might as well just go back to the same place, and hopefully they've learned their lesson and it'll be straightened out. And it was better the second time. So as far as the procedure, you know, they're gonna make you take off any outer clothing, no hats, no coats. They're gonna make you empty your pockets. They'll probably give you a little cabinet or something to lock up your personal items. You're gonna need a photo ID, so you gotta take a photo ID. And then you're gonna go into a bathroom and they've either turned off the water. What we did in the hospital was we actually had a little pill kind of thing that we would drop in the water and it would turn like a fizzy and turn the water blue. Yeah. But then they gave us a bathroom that we could actually physically turn the water off outside the room so that they couldn't flush or they couldn't wash their hands. And so we would send the patient in and they would collect their specimen, and you tell them, don't flush, don't wash your hands, don't do any of that. Just literally hand the specimen right back out to us. And it's important for you to know, now a lot of them actually have hand washing facilities outside the room, so that when you come out with your specimen, you can then wash your hands outside the room. It's important to watch your specimen. So if you're handing your specimen to somebody, don't just, you know, leave and do whatever. They're going to take that specimen cup, and on the specimen cup is a little thermometer. So they're going to measure, you know, it's kind of like one of those thermometers you put on a little kid's head to tell you what the temperature is. And it's going to tell the temperature of your urine. It has to be between 92 and 100 and something. 92?
94 to 100 is what's on
Is it 94 to 100? I can't remember. Anyway, so then they'll measure the temperature, and then they will pour it off into either 1 or 2 cups, depending on what, I don't know what the college orders, whether they want a split specimen or not. And then they're gonna have a piece of security tape, and you're gonna have to initial that security tape and then put that on your specimen when they label it and everything. And so you need to make sure that your specimen stays within eye shot of whatever they're doing with it. Yes, ma'am.
What happens if the person is taking, when I was doing my phlebotomy at clinicals, they were doing this, but what if the person's got a fever? I mean,
It's got a what?
has a fever, their body temperature is gonna be higher than 100, most likely, which means that their urine will be higher.
Well, don't go when you're having a fever.
care about higher, probably lower.
Yeah, yeah,
For people to bring in other people's urine.
yeah, 'cause, yeah. And again, even if you strap it to your leg, it's not gonna be 94 degrees. Yeah. But anyway, where was I? So then, and then it has to follow a chain of command. So it will go, whoever collects your specimen, you'll sign a piece of paper saying, I gave you my specimen. You're the one that collects it, you'll sign saying, I got the specimen. And then a courier that comes and gets it will have to sign and say he has the specimen. And then when that courier takes it to the lab person has to sign and say, we got your specimen. There's a place in Collinsville, and I know does a lot of drug screen testing for employment and things like that. And actually one of my medical assistants got a job there. And she basically gets locked in the room at 8 o'clock in the morning with the specimens. Nobody can come in, talk to her or anything. She does her drug testing. When she's hungry, she knocks on the door and they let her out, and then they lock the room. And yeah, it's really an ordeal. She loves it though, because she can play the radio as loud as she wants. They don't care. And then she hasn't messed around with anybody. So if that's something you like, is solitary confinement for 8 hours, then that's the job for you. But she absolutely loved it. But I don't know if you would be called for, I don't know, if you had to be called for legal and stuff like that, that would be the end of me. I don't think I'd want to do that. Anyway, she liked it. And let's see, what do I want to know about controls? When you do a drug of abuse screen, and like I said, we have some here we can play with, there are multiple drugs on a single cartridge. They're a lot like a pregnancy test. Have you done pregnancy tests in here yet?
Next week.
Oh, next week. Okay. Anyway, so a pregnancy kit cartridge is a little plastic cartridge, and it has a well where you add your sample, and then the sample just basically migrates up. And if you're positive, it'll turn the line pink, and if you're negative, it just keeps migrating. And there's always an internal control. So there's always a line on this paper to let you know that the test worked, okay? So with drug screens, it's the same thing. But there can be multiple drugs on a single cartridge. The ones I have a negative and positive control with about 3 drugs in between, and then there's another little section that has a negative and positive control with a few drugs in between, and so on. So it's like 3 different 3 different sets in one cartridge. And so it's important to know that if you're seeing how you have 3 separate sections and you have a negative and a positive control in each section, you don't necessarily have to disregard all of the drug testing. So if there's 3 different drugs in one section and your positive and negative control didn't work in that section, you can still accept the sections that worked. Does that make sense? Okay, so you don't have to redo it all. We a lot of times had, when we do it on an instrument in chemistry, you would have a control for cocaine. You would have a control for benzodiazepine. You'd have a control for amphetamines. And so you had a different control for every drug. So you would then run your controls, and if, let's say, it worked for everything except cocaine, you could still put your drug screen on, and you could still release everything as long as their QC worked. You just wouldn't release cocaine. Does that make sense? So it's kind of like you have a Chem 8, your glucose control didn't work, but your electrolytes did. You could release your electrolytes and hold your glucose result. Does that make sense? So again, you didn't have to hold up the entire drug screen just for one single result. So again, there's alteration monitors. Again, the temperature, the little temperature thing on the cup. And again, shut off the water or put the blue thing in the water, and then again, chain of custody. So again, it's important for you to know that that's what they're going to go through. And so you need to pay attention because it is your specimen, you know, and if it comes back and you're like, oh, well, shoot, I just handed her the cup and walked out the door and it comes back positive, what have you got to back you up as far as that was really your specimen? So keep them honest, make sure that they do it well. But again, just to let you know that you're not going to be able to pick anything when you're in with you. Last one I had for a job, they actually had my purse and they put it in a cabinet, locked it, and then gave me the key. And then I just kept the key in. And we were done. So I didn't tinkle all day long, and I had to go something. So other toxic drugs, again, carbon dioxide, and that's what's carbon dioxide. Yep. Cyanide. You guys dealt with cyanide when you did your hemoglobins, remember? Cyan-met hemoglobin. Okay. So again, cyanide. A lot of people use cyanide to kill people, but you know they're getting smarter these days, so they can figure out where you got it. Pesticides again will inhibit your cholinesterase, so your cholinesterase will be decreased. That's just some symptoms of when you have those problems. Carbon monoxide is when you have incomplete combustion. So that's a lot of times when you have furnaces and things that are running in the wintertime and it isn't ventilated very well. You have carbon monoxide poisoning. I used to be so fearful of this when I worked night shift, and I was just always scared to death. That's when I come home and find my family all dead. That's when it was cold and heater was blowing. Yeah, that's those crazy things you get in your head. You know too much, and it's just kind of scary. Too many episodes of these, emergency shows. But anyway, again, make sure you get air. Make sure it's all working. Have the furnace checked. Other things, metals, arsenic. If you have arsenic poisoning, you'll have what's called Mees lines, and Mees lines are dark lines in your fingernail. Okay, garlic breath will smell garlicky, cause vomiting, bloody stools. So Napoleon Bonaparte, actually they dug him up and they used some of his hair, because hair doesn't really go away when they bury you, and used his hair and found out that he had actually been poisoned with arsenic. And so when they look back at pictures of him, they always saw pictures of him putting his hand in his jacket or whatever. So they were just kind of surmising that it's because he had abdominal pain because they were actually poisoning him with arsenic. Mercury poisoning, you know about this one, right, with eating certain shellfish and eating fish and everything with mercury. A few years back, we were told we had to get mercury out of the laboratory, so we had to get rid of all of our mercury thermometers and get rid of all that. Yes, ma'am?
What is the poison that makes your breath smell like almonds?
I don't know. Is there a poison that makes your breath smell like
I
almonds?
thought it was arsenic.
I think it is arsenic. I heard of arsenic too.
I don't know. He has more homework, huh? So again, we had to get rid of all the mercury, and now we are not allowed to buy any kits. Some kits still have mercury in them, so we're not allowed to buy any kits now that have mercury, so we have to find an alternate. We actually received some supplies, and on our EDTA specimens, histology uses EDTA for some of their tissue processing, and the EDTA box had a label on it, you know, caution contains mercury. And so of course that sent up a red flag, and as a safety officer, of course, they hand it to me and say, Barb, investigate this. And so I looked at the safety data sheet, and the safety data sheet did not say one word about mercury. And so I called the company and I said, well, wait a minute, you know, if you're putting this caution label on this substance, why doesn't your safety data sheet say that it is? And so she actually asked me to make a copy, you know, put it in the copy machine to make a copy of the label and everything, and come to find out there was no mercury in the reagent, okay, the EDTA reagent. Somebody had just accidentally put the wrong label on. And because the company was Remmel, but it was because it was their German counterpart, so that became an international incident. I have papers to prove it. Yeah. So, okay, so that was very, very interesting. Lead poisoning with like lead paint, and back in the days when we had leaded gas, which of course we don't do that anymore. So again, can cause developmental problems in children. I was reading a CDC alert a couple months ago where they had a child, because you know nowadays they test children at different age groups, and I think you always get a lead test before you start school. But I think at certain ages as well, if you're living in a certain area or if your house is a certain age or whatever, they'll do lead testing. And so they were actually doing lead testing on this child, and it was extremely high. And so they went through and you know, is it in the paint, is it in the air, is it in the soil, you know, is it in the backyard where the child plays or whatever. Come to find out, the father worked in a battery plant or something where there was lead, and he would come home, and of course the daughter, oh, daddy's home, he would, you know, scoop her up and they'd play and they'd read and, you know, hug and everything else. And so he was actually bringing home the lead on his clothing, and it was being absorbed by the child. And so the company, because of course that involved the CDC and everybody else in OSHA and everybody got involved, then the company then, their answer to the problem was to provide uniforms for their employees, and their employees would then come to school, come to work in jeans and t-shirt, whatever, would change into their uniform of the day, and then they would change out of their uniform of the day and come back home in their jeans and t-shirt. That was how they resolved the issue with them. So again, we call them take-home hazards. We talked about that. We did bloodborne pathogens. So back in the day when my kids were very little, crawling on the floor, I would not wear my work shoes home. I actually wore tennis shoes to my locker at work, changed into my work tennis shoes, and then at the end of the day changed back, because I thought, I'm walking in a lab with who knows what on the floor, you know, and so I wouldn't take them home. Your cell phones are a big one. You're gonna be doing microbiology in the spring, right? You're gonna be dealing with a lot of bugs, okay? And these aren't necessarily good bugs. These aren't things that you wanna get a hold of. So again, you wanna use aseptic technique. But how many times have you guys reached into your pocket because it's chimed and you got a message or something, and you reach into your pocket? So you need to be really, really careful. Jean's gonna monitor it pretty close too, as far as you having cell phones out in the laboratory during that time. But it's not just bacteria, I mean anything, bloodborne pathogens, anything on your cell phone. So they tried to make a standard, CAP did, that said that your cell phone had to be cleaned before you left the laboratory. So that would have meant that hospitals or any laboratory would have had to provide a cleaning station basically at the door as you're exiting, and it never was passed. CAP was never able to enforce it. We did have to write a policy, but it just says should be cleaned. It doesn't say that it's mandatory. So again, just something to think about as far as, I mean, do you clean your cell phones now? Do you, don't they sell little wipes or something that you can use and things
I use
and so hand sanitizer? So, yeah, so again, that's something to pay attention. I've seen people in like Walmart or whatever, and their little kids in the front, in the little cart, and getting irritated and fussing or whatever, and I've seen them take their cell phones out and put a little movie or something on and hand it to the kid, and it goes right into their mouth, and I'm thinking, oh dear, right? But again, are you a germaphobe or aren't you? So, I don't like when I see little kids chewing the handles on the Walmart cart either, but yeah, yeah. So again, they now have little hand sanitizer things that you can do with your cart. But again, it's just something to think about. Take home hazards.
So it's cyanide that smells like almonds.
Oh, cyanide?
Yeah.
Okay, there you go.
No, I don't think it smells like almonds. I think it tastes like almonds.
No, it says it smells like bitter almonds, but 40% of people are genetically incapable of smelling it, so.
Cyanide? So I guess I can add that to it, huh? So yeah. So if you have lead poisoning in children, the treatment is to do EDTA. EDTA again chelates your calcium. That's what keeps your blood from clotting when you draw it in a Vacutainer or two. And so if we give you EDTA, it will bind the lead, and then you'll be able to pass it in your stool. So does anybody have a soda in a can? Have you ever looked at the ingredients in canned
It's coffee.
coffee? Does it say EDTA as an ingredient?
I think it says
Notice
No.
I've seen it in like different sauces.
Do you know why it's in there?
It's preservative.
No.
Really?
Not a preservative.
To keep the ingredients from separating?
If there's any metal that leaches out of the can into the product, the EDTA will chelate it, and instead of that, your body then absorbing that metal, it will literally be passed through your feces. So that's what EDTA is.
Huh.
You're drinking anticoagulant. Interesting. Okay. How it's determined, again, either the spot test or spectrophotometry, immunoassays, gas chromatography. Some methods that we would use. And then again, just some methods that we would use too for certain things, but nothing major. Any questions?
Seriously, and the acetaminophen, do the levels go down before they go up? I was always under the
Go
impression.
down before they go up.
Yeah, I was always under the impression that like if a patient came in with salicylate or acetaminophen poisoning, they would be a certain level when they got there that they'd go down before peaking.
The only thing I can think of is because the level in your blood would drop, but then once what was in your tissues then got into your blood, your level could peak, is the only reasoning I can see behind that. But I don't know, I've never heard that before.
So it's creating an equilibrium between serum and the.
Yeah, that's the only thing I can think of. But I've never heard that before. It'd be interesting. Go take a potty break. So what would you do?
I would take the 10 mils and add another 37. That would give me 6%.
Correct, correct. So we get a 10 mil vial of 22% albumin, but the procedure calls for 6%. And so we have to dilute the albumin to 6%. And so it's just simply a weight volume times concentration equals your second volume times concentration. So she did it right. So we just add 37 milliliters of saline. It has to be saline because that's what the procedure says to do to a container. Yes, we do. Okay, who wants to do number 2? This is easy.
I think so. I got these right here. The 49 water. then.
Yes,
That's okay.
exactly. You just said it backwards. That's fine. That's fine. And so this is the actual wash, the actual one that we actually have to make for our coag analyzer. Okay, so then number 3 just builds on to what he just did. So who wants to do number 3?
So it's 1 of water.
No, 1 mil of wash concentrate to 49 mils of water. Gives you a 1 to 50. Which do you think you want add to the jug first? Just add a hoots and hollers?
The water.
Why?
You always add. It has more sensitivity.
And it's not that it's an acid, it's because it's a soap. And so if you put the soap in first and then add your water, what are you gonna get?
Bubbles.
Bubbles, yeah. So that's always a good. Same with the SDI clean in the CA240, where you add the water first and then add your CI clean and then give it a little shake, otherwise you get too many bubbles. Yep. Yep. Okay, so number 3. Which again is gonna go off his. So we have a great big huge jug, and you're right, we add 10 to, again, 490 mils of water. And we just use the the really big graduated cylinders. And again, it's not exact, okay, so we don't have to do a little pipette and make sure it's exact. So we use the great big huge graduated cylinders. And so again, you add your water before your wash solution. There are some people that will do like half the water, then add the wash solution, then carefully add the other half, and that way it kind of mixes it. They don't have to try to pick up that great big huge jug of 500 mils and mix it. So again, whoever's teaching you'll tell you their little trick of the trade. But again, so that's something that we again have to do. And what we do in the lab is we make 2, and then when the one is empty, you've got that second one to put on right away, and then you would make the second. So in other words, you never have you have 2, and you never have an empty one. So because if it starts getting low, you can immediately change it over because the machine is running through water like constantly. So you want to make, just like on our CA240 here, if we were using that all the time, we were afraid we were going to want to run out of wash, we would want a second container so that we could just immediately put it on there. So again, as a student, that's going to be one of the things that they're going to tell you, in your first week, okay, your job is to empty the waste, and your job is to fill this reservoir, and you need to look and see how much is left in this one, and is the other one full, and when are you gonna have to change it over, and then of course, when you change it over, they're gonna tell you to dump out what little bit of residue is left in the first one and go make the second one, because that's just fun stuff that they like to give students to do. And they're probably gonna tell you how to do it the first time, and then the second time, they're going to assume you know. So again, Jean has probably talked to you about having a little notebook in your pocket, right? And so again, that's something that you would want to write down. On day 1, empty the trash and fill this and do that, so that on day 2, they might help you a little bit if you can't remember everything, but at least you got to be able to try. Because let me tell you, by day 3, 4, and 5, they're not going to want to have to tell you again. And so you want to be on their good side. And throwing away trash and filling up buckets is really, really easy. Once you know where the cylinders are, once you know where the wash concentrate is, just do it. Just do it. Taking your temperatures again is something, just do it. You don't have to ask for permission. Okay, so that was number 3. Okay, number 4. And you can stay at your desk and just talk through it.
Don't you just dilute it? You do.
What would you dilute it? How would,
We don't even have a,
You start with, right.
so,
Wait,
so
it's
what do you
it's all
know?
1 to 10.
Okay, what do you know? What's normal for glucose?
60.
Correct, okay? Your range is 500. Your linear range is to 500. How high is a patient's glucose really gonna get? Is it gonna get to 10,000? Right, okay? So you have to take an educated guess. How much of a dilution am I going to need?
Let's go to 1,000.
I'm sorry?
1,000.
So if it's overranged high at 500, what would be my first guess on the dilution that I would make? Would you do a 1 to 10?
No, it's 5,000, right?
So what would you do? 1 to 2, because that's easy, right? 1 part of whatever the diluent is to 1 part of blood, 1 to 2, right? Okay. So you can dilute it 1 to 2. So number 5, explain that one.
Multiply 275 by 2.
Exactly, so you have to multiply whatever result you're getting, you have to multiply it by your dilution factor. Okay? So again, if the patient came in through ER a couple hours ago, and this is the second glucose that they're running, and they were 1,200 in ER, right? So maybe you did a 1 to 3 and still got 275, you would then multiply it by 3, right? Highest glucose I've ever seen is like right at 1,000. That's the highest. My lowest was 7. So yeah, it's gonna stay within that range. If you're doing it on a glucometer though, and your glucometer says it's overranged high, can you dilute a fingertip blood? So what do you do?
To the lab.
Yes, you send them to the lab for a blood test. They have to draw the blood and do it that way. Okay, number 6.
What is that measurement? U per I?
Units per liter.
Okay. Okay.
Again, it's gonna be, depending on your lab, a lot of times it's SI units or international units or
Okay.
whatever. But normal values in the textbook that I was looking up just get said units per liter.
Okay. If it's within.
So what do you know about amylase and lipase? Again, you have to take it and have an indicated guess.
Hand in hand.
I'm sorry?
Amylase and lipase go hand in hand.
Okay. For what disease? Pancreatitis. So what do you notice about your amylase result? Or I'm sorry, your lipase result? Okay. It's within range, yes. So you could report that, right? Because it's within your linearity. But if they're both elevated during pancreatitis, why would it have an amylase of 1?
Maybe pancreatitis. Something else affecting me.
Usually, you said it first, they went hand in hand. Usually when one elevates, the other one elevates.
Yeah, but only in pancreatitis. So if they're not
And
both
that's the
elevated
major
at the same
cause.
time-
And so usually they go hand in hand. When one's elevated, the other one's elevated.
Would you redo the test?
Which one?
Amylase.
Because we would
Amylase?
assume your lipase is okay. It's within linearity, right?
Are we thinking
Okay.
carryover?
Not carryover. Something very interesting with enzymes, okay? When you're measuring enzymes in chemistry analyzers, if the result is high and at a linearity, it will sometimes give you a false low number. Okay? So you would think, okay, it's within linearity, I can report out a 1. But something should trigger in your head, wait a minute, if their lipase is that elevated, okay, again, you could look up their diagnosis or find out what they're in there for, okay? But you need to know that sometimes if amylase and lipase are usually elevated together, which they are, okay? And your lipase is that elevated, why would I have an amylase of 1? Something's wrong, right? So the first thing you would want to do, what's the first thing you always do before you ever go ask anybody for any help?
Redo it.
Repeat it, right? Because they burp. Chemistry analyzers sometimes get a bubble. They just burp, right? And so before you get your panties in a wad, you just need to rerun it, right? Now if I got an amylase of say 299, whoo, I'm good, right? I'm in linearity. Now my amylase is elevated, my lipase is elevated, makes sense. Pancreatitis, correct? Okay. If my amylase result was, say, 350, what would I need to do? You have to dilute it. Exactly right. Now, because it gave you a result of 350, you know it's close in the ballpark. So what dilution would you do? Just a simple 1 to 2. Okay? Just again, an educated guess. Okay? And you got to realize too, you have enzymes in your body. It's just like if you got a glucose of 1, you know you've got glucose. If this patient is alive, you know they don't have a glucose of 1. So again, you have to have an educated guess that this isn't right. I need to repeat this. So before you start calling the nurse and getting them all upset because this patient has a glucose of 1, just simply repeat it. Okay? Okay.
So we would just repeat the
Just
test.
say, what do you report?
So again, you would do a 1 to 2 dilution. That's where I would start. And if I got within linearity, I would report out what I got times 2. If I got 900, you probably need more than a 1 to 2, right? You need a 1 to 3 or a 1 to 4. Okay. So again, just an educated guess. What would you also, how would you also document that so the next person coming in wouldn't do the same, have the same problem? In your, you have a little manual or a little notebook, and where you have to actually write what the problem is. And we actually have to write, if there's nothing to tell the next person, you just simply put in DNR, do not report, or nothing to report. That's NTR, right? Nothing to report, yeah. But again, so that you paid attention that you wrote in the book. Okay. Number 7. Is it less than 0?
No, just report as
Okay, here's another one. What's your normal for total protein?
8 to 10.
8 to 10. No, 6 to 8. 6 to 8, right? Roughly 6 to 8. Do you have protein? What is in your total protein? That's your albumin. That's your antibodies. That's everything, right? So would you really have that low of a number on a total protein?
No.
No, something's wrong, right? You would not have that result. Because the person's alive, okay? You know they have protein. 0.5 is just astronomical low. So again, what would you do? Rerun it first, absolutely. Rerun it. Another clue bird would help you is look at some of the other results, right? If they had a Chem 8 with a total protein, and their calcium is normal, and their glucose is normal, and their electrolytes are normal, okay, something just burped with the total protein. But if you're looking at the other results, and sometimes an H&H is a really good one, so you may call over to the person who's doing the CBC. Say, hey, did you get the CBC on Bob Smith? And they go, yeah, his result is like half of what he used to be, must be bleeding out. What's your problem? It was diluted and drawn above an IV. All right, so if you're looking at your other results and they're really low too, and again, a big one to ask is your hematology person, because they have to look, right? If their hemoglobin or hematocrit jumps up or drops down, they need to investigate too. So if your total protein is really low and their H&H is really low, you're thinking, oh, okay, they drew it above the IV. Okay. The worst one for this again are your ER draws, because they'll give them a bolus of something and then they'll draw the blood, and you'll get really backed out results. So again, you need to know something isn't right. Something doesn't look right.
linearity really start at 0 if more normal starts at 8?
For
I mean-
some, and that's actually that is the linearity for our manual procedure, is 0 to 10. For the manual total protein that we did, that's actually the linearity for that procedure. Yep. Okay. Number 8.
Did you just report it?
Greater than
Like,
300?
What would you report?
Greater than
Yes. So again, if the procedure says don't dilute, you would just simply report it out greater than the higher linearity value. Okay? A lot of times it's with your troponins, you don't dilute. Some of your cardiac enzymes, you don't dilute. Because the linearity is really much higher than 300. It's a lot of times 1200 or something like that. And it's like, okay, if you're that high, then we know there's a problem. So you don't want to dilute it. Okay? Again, the methodology doesn't want you to dilute it or for whatever reason. And so your procedure will say do not dilute. So again, we have little cheat sheets where we have cheat sheets. And they are stapled together and they're laminated so that you can wipe them down if you get anything on them. And it literally has every test listed and tells you at what level you can dilute. You know, the highest you can dilute is say a 1 to 10. After that, you would report out greater than. Or maybe you can dilute until you finally get an answer, okay? It will also tell you what your diluent is. And for some, it will say do not dilute. So again, we're not geniuses in the lab, we just know where to find the answer, right? So you need to know where that cheat sheet is. Okay, chemistry, it's on the main analyzer.
Yeah.
So again, we're not geniuses. Sometimes there are actually little laminated sheets that are right on top of the machine, okay, in the analyzer. So again, you just need to know where they are. For our cardiacs, it's just on the wall right in front of the machine that does our cardiacs. So again, you just kind of have to know where everything is. The bad thing is that after a while, everything looks familiar. Everything, you don't notice anything different. Does that make sense? When I do an inspection, because that clock is on the wall all the time, I don't think anything of it, but one day the glass might be broken. But it's just the clock on the wall, I didn't pay attention. But then if I walk through with somebody else and like, hey, the glass is broken, that's a safety hazard. Oh yeah, okay, I didn't, because the glass is all the time. So you're gonna get to where things are familiar and you're not gonna notice a new one on the wall because there's so many papers on the wall. So again, usually when it's that case, we will highlight it or we will put something there to get your attention, put it up as on a yellow sheet for a while and then change it to a white sheet or something. So you need to be familiar and aware that we'll do kind of things like that in the lab. Okay, so that was number 8. Number 9. Size of the book.
Just report out.
Less than
Just
4.
the next 4.
Linearity is 4 to 60 and you get a 2. Yes, you're just gonna report out less than 4. Because again, that would make sense, right? What is the reference range for acetaminophen? 0, right? So having a 2, oh, okay, maybe they took a Tylenol yesterday. Still have a little bit in their blood, but that's nothing shocking, right? Wouldn't surprise you at all. Okay. Number 10. What's normal for potassium? 5. So you have a 7.2. Exactly. You didn't put the specimen on, correct? So before I reported that, I would want to go find that specimen and I would physically want to look at it. So if the specimen was hemolyzed, what would you do? Have it redrawn. Exactly right. Have it redrawn. Have it redrawn.
What if it wasn't normalized?
That was my next one that I was going to put on here and totally forgot until this morning. Okay? So you look at that specimen, you take it off the machine, and it's not hemolyzed. And you're thinking, dang, this patient has a 7.2 potassium, that's pretty critical, right? But they just happen to have a calcium too, it was a Chem 8. And you see that your calcium is 5.6 milligrams per deciliter. What's normal for calcium? 8 to 10, so 5.6 is pretty significant, right? If you draw incorrectly with your not correct order of draw, and you draw your EDTA specimen first, and you have EDT contamination, it will bind calcium because it is potassium EDTA. It's either dipotassium or tripotassium. It's either 3 or 2. Okay. Another thing, if phlebotomists draw blood with a syringe, and they're then filling the tubes with a syringe, and too much goes into the tube, they will sometimes draw it back out so that they can then put it in the chemistry tube. Don't laugh, it happens all the time. Well, not all the time, but at least a couple times a year. So again, if your potassium is low, or your calcium is low and your potassium is high, you would then order a redraw. Because that's something that you need to realize, okay? Patient is not that low.
We recently had a nursing home do that, and they said, you need to read that, and they're like, no, why? It was fine. They're like, no, you guys poured over from a purple cup, and they're like, well, can we have the other results? No. They really, really wanted the other result besides the calcium.
Again, that's why order of draw is important, and again, why they're not interchangeable. Exactly right, exactly right. And again, you have two different green tops. One is sodium heparin, and the other one's lithium heparin. Right, one's dark green, one's light green. So do you want to use a sodium heparin tube for your electrolytes? No, you don't want to use the dark green. Do you want to use a lithium heparin for your lithium testing? No. So again, pay attention to what you're using, what you draw. So nowadays it's pretty easy because usually on the label, everything's automated now. It's on the label, it'll tell you exactly what tube to draw. But we got rid of all of our sodium heparins because phlebotomists were pulling them by mistake for Chem 7s and things like that. So we just switched to lithium heparins. And then for our lithiums, we just went to a red top.
What's the difference between a Chem 7 and a Chem 8?
I'm sorry?
What's the difference between a Chem 7 and a Chem 8?
Usually a calcium. Chem 7 wouldn't have a calcium, a Chem 8. So again, you can have a Chem 12, Chem 14, Chem 26. It just depends on how many tests they've added on.
And then I was just thinking
How many tests are in there? Yeah, it's just an orderable test. Our Chem 26s are for like physicals. You come in to the doctor for your annual physical, he'll order like a Chem 26, which will give you one liver enzyme, one cardiac enzyme, one kidney test, one TSH, or one this or one that. So yeah, so then if it came back and your cardiac enzyme was elevated, well then we might order a cardiac panel. Or if one liver enzyme was elevated, you might then order a liver panel. Or if your cholesterol came back, okay, we're gonna order a lipid panel. So it's just kind of like, again, for like a physical, where we just wanna make sure if everything in your Chem 26 was normal, we'd say, okay, you're normal. You know, especially if you weren't aching or hurting or anything else, we just say you were normal. Does that make sense? And then again, they pull it apart there. Okay. So last one. And I added this just because it's on your test.
30 divided by 4, 30 times 100.
What's your answer?
7%. It's 6.97.
Wait, how do you do it?
30, you take the iron divided by the total iron binding capacity, times it by 100 to get the percent.
And actually, when I was doing this, my husband was bugging me because I was in my office and he was lonely. And he wanted to know if I wanted ice cream. I was on this question. I was like, just wait a minute. I just got one more question to do. And he looked hurt because he must have really wanted his ice cream now. And so he left. And then he said, well, I'll make you some. And I said, no, I don't want it to get soft. Just hang on. I'll finish this and I'll go eat my ice cream. And so I heard him in the kitchen eating his ice cream. The next thing I know, he plops a bowl down in front of me. And I was not happy, but you know, half of me was tempted just to go to the toilet and flush it, but I was ticked. but then I thought, no, I really want the ice cream. So that should not be 130. TIBCs normally are like 20 to 50. So a person with iron deficiency anemia, because your iron is low, right? That was 50 to 175. Your TIBC in an actual problem would really be like 130, not 430. So that was just my typo, and we can just blame him. Any questions? But there are some math problems on the website that are more of like what Jean went through with you for 150.
Page 13, 14.
Hang on just a second. For your test. And then we have to lecture on body fluids. And one other thing, right? Body fluids. There's a quiz on body fluids, so I'll just give it to you and you guys can do it together if you want, or do it by yourself or whatever. I showed you this last time. Do that.
You can start lecturing, I'm okay.
And everything's due for you this Friday or next Friday?
Everything is due for me, like your article or your disease state and anything that's outstanding. You have a COBOS or a CA 240 competency that you need to turn into me. And so anything that's outstanding would be due by next Friday.
Will you have like the CA 240, what I told you was copy off of it, so you know what to put on the copy?
You can just pick a reagent as far as what you want to do. I can give you a lot number.
I guess so, because she has her phlebotomy down
The CA24 competency is not in here, is it?
Should be.
here. What's CEU?
Protein electrophoresis.
Electrophoresis.
Okay.
Now, do you turn that into me, or do you just put that in your portfolio? How do you do that?
Previously, we just show it to you, put it in there.
Okay. Whatever you do for Jean.
Are you sure you want a disease state?
I will take either a disease state or an article. Does not matter to me.
What kind of like article,
Like,
like
where's
example
it
or
from
something?
someone?
An article, what I accept is, let's say you're sitting down reading the Belleville News Democrat, and there's an article on a patient who went into diabetic ketoacidosis. And they were rushed to St. Elizabeth's Hospital, and we worked a miracle, and we brought him back to life. And you thought that was a very interesting article. And so you just wanted to write and tell me about the patient who had ketoacidosis, and you know what the article said, and what you know about ketoacidosis. Or you can just do a disease state that says my disease is diabetic ketoacidosis, and it's in the, you know, the disease state and questions that you have to answer on the disease state shirt. Or you can go to an actual periodical. So she has lab magazines in the lab up on the top shelf where you get your lab coats, and you wanted to pull one down, and there was an article in there on how we're preventing diabetic ketoacidosis because we're putting insulin in water now. I'm just making this up. Yeah, just making this up. But again, so then you thought, well, that was a very interesting article. So then you read the article, and then you answered some questions about the article. So whatever you want, I will accept anything. In blood bank, I'd say most students do the article because they like to go on the internet and do a little research on like a fake blood product. There's actually a really interesting article about what you should eat depending on your blood type. So if you were an A positive, you should stay away from peanuts. And if you were an O positive, you should eat more broccoli. I'm making this up, but there's an actual article out there that tells you that you could eat based on your blood type. Or fake blood products. I get fake blood. I've had people that have, because we do talk about animal blood transfusions, and so there are people that'll read an article about blood transfusions between dog to dog, or cat to cat, or horse to horse, or whatever.
And we summarize the article or answer a certain set of questions about the article?
There is a set of questions, an actual set of questions, so you basically, and
Who, what, when, where, what?
In the.
I think it's in the syllabus, yeah, where it says what's the name of the article, basically, generally, what was the article about? You know, that's just a quick couple, 3-4 sentences. Did you find the information helpful, or would you recommend this to another student to read? Or, you know, so some of them are just yes, no answers. So it's pretty easy too. So even if you found an article like on the internet or something like that, I would accept that too. I would just ask you to print it. And because I couldn't actually go to the periodical. I have been known to take a line or two out of somebody's writing and Google it to see if it's plagiarized. And I have found people that have plagiarized, so then you get a 0. So don't just copy the first paragraph from the article and say, okay, I read the whole article. I can find that out.
It's better to do disease state.
And that's perfectly fine too. A lot of students do. But it just has to be chemistry related. Because I've had people turn in ones that are rheumatoid arthritis. Well, that's not really chemistry related, that's more, you know, serology or something like that.
Is multiple myeloma acceptable in chemistry? Or did I use that for my hair analysis? I wrote it up, but I'm like, it touches on a lot of things, but I don't know if
But
it's
multiple myeloma is not really one we deal with
Yeah,
in
okay.
chemistry a whole lot. We touch on multiple myeloma, we talk about it a little bit in blood bank, but it's not really a blood bank one either.
Oh, you did
It's
for my
really
hair
hard,
analysis.
a disease state in blood bank is really, really hard because there really aren't any disease states in blood bank, you know what I'm saying? There are disease states that would cause you to have to get blood, but there aren't really any disease states. So then usually an article in a magazine or something would be better.
Is that the competency?
No, not for CH40.
So, oh, no, I got the color smear.
Posting that you're on for all that. Because I have one for Cobas Mira too, and of course. It's ABGs, blood gases, electrolytes, and trace elements.
So everything we went over yesterday.
I'm
Yeah.
posting that today.
Your next test is TDM and PCR.
And body fluids?
No, body fluids will be a separate quiz.
Oh,
So
just
we're
a
gonna
quiz.
lecture on body fluids tomorrow, which is like 6 slides, it's not real
Yeah.
big. And then I'm gonna give you the quiz and you're gonna do it, and you're gonna turn it back into me. And I'll let you work together. Not a big deal. I used to have all the body fluids incorporated into the lectures that they were in, and then Jean asked me to pull them out and do it separate, because apparently she does body fluids separate. So chemistry body fluids versus like hematology body fluids, or urinalysis body fluids. Now we are seeing them in the department, especially with our microbiology department, for bacterial identification and for STD identification. So we are seeing it a little more into the actual department. So this lecture is actually kind of old, but it kind of gives you an overview of how it kind of came about. So you know everybody has DNA, right? And every DNA is pretty much unique for every individual. It's kind of like your fingerprint, right? And so we can identify a particular person by finding their DNA, and that's how we find the killer from the cigarette butt that he smoked outside the house when he went in to kill the people. The forensic files, I don't know if you like that show or not, but I just watch it incessantly. My husband must think I'm gonna try to find a way to kill him or something. I got, but that and yeah. So anyway, I just think that's really, why people think they can get away with stuff is just beyond me, because I don't think you can anymore. But anyway, so again, we have DNA, and so each individual is different. So if we get a piece of your DNA, we can figure out where you've been and who you've been with, and if you killed anybody, right? Because you always leave DNA behind. Getting a little more specific, but again, we were gonna go a little bit more back into history and we'll talk a little bit about it. So what is PCR? It's a quick and easy method to make copies of DNA. So if you're smoking a cigarette and your saliva is on the end of the cigarette butt and you only have this much DNA, we can use PCR as a way to make more of it, to test it, okay? So we'll get into that in just a second. So tiny amounts of genetic material, and we just simply make photocopies of it, if you will, so we have more of it to play with. So the theory, again, uses the natural function of enzymes, known as polymerases, and it basically acts like a zipper. Do we have to leave? No, I guess we don't. I was thinking some people in the hallway, I was thinking, oh gee, we're gonna get chased out of the room. What is today, Thursday? See, I don't know Lizzie's for Thursday. I guess not. Jean doesn't get chased out, does she? We'll knock on the door, I guess, if I'm in trouble. So again, enzymes are present in all living things, and again, it acts as a copy machine to copy your genetic material. So again, called molecular photocopying. Let's see, so we can find it through blood, hair, tissue, microorganisms, animals or plants. Again, things that are a million years old. So just some definitions for you. What is DNA? You know what DNA is. The primer is basically, so you have your DNA strip, and then you're going to tear that apart. And so if you kind of think about it as railroad tracks, and you just kind of rip down the middle of the ties, and you have two separate pieces of railroad track. And then you know how a zipper works, right? You zip it, and the little teeth go together. So you have a little primer that acts and kind of builds the zipper of the other half of the DNA as it goes and builds your strand of DNA. And so the Taq polymerase is the enzyme derived from the Thermus aquaticus bacteria that lives in hot springs, stable at very high temperatures. So you guys are way too young to remember that back in the day, okay, when you had all temperature cheer, right, because you know you had to wash clothes in hot temperatures to get the dirt out, right, but then all temperature cheer came about, and you could actually wash your clothes in cold water and it still got, you know, grass stains and stuff out of your clothes. And so everybody's like, well, gee, how can it do that? Again, somebody discovered an enzyme in the deepest, darkest, coldest parts of the ocean, because obviously whales die, and you know, you don't go look down there and find a zillion whale bodies, right? So something has to eat them and get rid of them. And so there's an enzyme that actually works in cold water. And so somebody discovered it and put it in their laundry detergent, and that's how come your laundry detergent can work at a cold temperature. So here they found an enzyme that's actually in the hot springs, and so this enzyme works at hot temperatures. And you know from having enzymes, right? When our enzyme lecture, we worried about temperature, right? We said if the machine was hot, we had to put a fan in front of it, we had to cool it off, because the enzymes in our body work at what temperature? No, not room temperature. Body temperature, right, 37. That's why we have to wait for my CA240 to come up to temperature, because it doesn't like being less than 37 degrees, right? So again, so where do your enzymes work? So the Taq polymerase is one that works at a higher temperature. And there are only 3 questions on your test from this lecture, and I'll tell you what all 3 of them are when we're all done. How's that? So again, what do you require? You need a template molecule, right? Piece of the DNA or the RNA that you want to copy. Primary molecules, a reaction tube, reagents, and a source of heat. And the source of, in it, it's really not any bigger than about the size of a microphone, so it's actually pretty big. So there are 3 basic steps, and you just repeat the steps over and over again to make more and more DNA. So the first thing to do is at 94 degrees, we're going to denature it. Basically take our double-stranded DNA and break it apart. And then you go through an annealing process, which is Brownian motion. You know what Brownian motion is, right? I mean, like when you're looking at something under the microscope and how the heat from the lamp will start making the substances, like your urine or whatever, stuff will start moving. So by using Brownian motion, you're healing it up. You're basically getting that little primer piece to jiggle and jiggle until it finds the right place to add on to the other part. I mean, you know how hard it is to get a zipper started, right? you know, you gotta get that thing lined up, and then once it gets lined up, it just sits right up. So again, with that little needling process, that's what it's doing, is jiggling around till it finds a place to get bonded, and then forms a strong bond, and then just basically starts copying the template. And the extension is basically at 72 degrees, where the polymerase can add complementary DNA to the single-stranded DNA, and thus you can make more copies of the patient's DNA. Easy. Some possible technical problems. So if I'm the person, I have that DNA from that person from the cigarette butt that was out smoking it, and you know, outside the apartment that killed the person, and I'm the technician and I'm sitting at the table and I sneeze. Whose DNA is it? My DNA or the DNA of the guy that from the cigarette butt? So again, you have to worry about contamination, right? What if a cockroach walks across your, you know, sample while you're making your thing? Now we've got the DNA of the cockroach, right? So again, contamination is a really big problem. Okay, so again, it could be that I go through this whole process and find out that it's cockroach DNA, not human DNA, simply because of contamination. Okay, so again, preventing contamination is especially important if it's in medicine or law, because if I'm the person doing the test and I sneeze, and voila, it's my DNA, did I commit the crime or did I just perform the test? So, need to be careful. So, some uses of PCR, okay? We can use PCR to detect infectious diseases, okay? In bacteria, fungi. They can use to detect like the AIDS virus. And it's really kind of interesting now because if you're infected with the AIDS virus, okay, they can trace it back to who actually gave it to you. You've probably heard this in the news where somebody who had HIV and had multiple sex partners, they were able to follow that back to that person. And if they knew they had HIV and they infected people, that, yeah, it's a big ordeal. You didn't know that? They can, yeah. There was actually one in East St. Louis, and he infected 34 people. And so they could trace the DNA back to that person. And they could prove that he actually knew that he was positive before he had, and it was young teenage girls.
Yeah.
And that was, yeah, so.
That was a long time ago. That was crazy.
Yeah. So again, something that they can do. Okay. They've actually used this method to detect active infections for middle ear infections for children, which actually helped with which antibiotic to prescribe, because unfortunately they were over-prescribing antibiotics for children with inner ear infections, and so we were having our superbugs causing coughs, so we weren't able to kill it. Lyme disease in joint fluid, again, quicker diagnosis and treatment, as Lyme disease is not something you want to mess with. So again, some things that we can do. Heliobacter, have you done the Heliobacter test? You've done that one already? How many of you were positive? None of you? Really? Wow. H. pylori? Did you use your own sample?
No, I think we used
Oh, you didn't use your own sample?
yeah, I think we used
I think we do
controls on that one.
Oh, well, you have blood, you ought to do your own. About 25% are asymptomatically positive.
Interesting.
None of your asymptomatically positive. Again, for STDs, for herpes, papillomavirus, or chlamydia, we do it in our lab for chlamydia and for gonorrhea, they're the ones that we do. Do you know that it's like 80% of the population in Russia is positive for chlamydia?
Really?
It's epidemic in Russia. Follow safe sex practices. Yeah, that's it's an epidemic right now. So yeah, 80% of the population is positive. And you know about the papillomavirus with the HPV vaccine that they're saying now you have to do it between the ages of like 12 and 17 or something, again, because they can be predisposed to cancer. There were about 60 PCR protocols that they could use, but again, it's business. And if we had a disease that wasn't real common, okay, so let's say 10 people out of 500,000 have it, is it feasible to do trials and to get that test out there when you're not gonna do it very often? Is there any return on your money? So that's why of all the ones that you could possibly do, there's really only about 10 that are clinical products. Again, how many people have chlamydia, or how many people get screened for chlamydia? Pretty high, you know, and so sort of things like that. So again, it's all about business, it's all about money. Is it anything that's really anything more we want to do? Again, for HIV, cytomegalovirus, you do know that cytomegalovirus, by the age of 30, 80% of the population is positive for CMV. So CMV is something that you're gonna get and you're not even gonna know that you got it. If you're negative and you're an adult and you can donate blood, believe me, they're going to be calling you all the time. Because neonates, babies, can only have CMV negative blood, and again, that's only about 20% of the population.
What is CMV?
Cytomegalovirus, it's just a virus that you, just out there, yeah.
What does it usually benefit?
I'm sorry?
What does it usually benefit?
It can make them ill, especially if you have a premature baby. You don't want to expose them to a virus just simply by giving them a blood transfusion. So you want to give them CMV negative blood. And again, that's only about 20% of the population, so a lot of times hard to find. I'm sorry?
How is that virus transmitted? Nobody knows.
No. No. So, again, could be through the air, could be through whatever. There's also one called the JC virus that is through water sources, not necessarily unclean, but like lake water, if you like go swimming in a lake or doing something like that. So it's just ones that you can get through that if you like to swim in, not necessarily swimming pools, but in areas, I don't want to say unclean, but you know what I'm saying, clean process or whatever. So just one that you get. I don't know if I'm CMV positive or not. I can't donate blood. So detection of variations or mutations in genes to diagnose inherited disorders. We can use PCR for that. My husband just found out he has a very rare genetic disorder called Britt-Hogg-Dubé syndrome, and it was actually discovered by his dermatologist because he had like little things on his face, and we just didn't know what they were. The dermatologist says, "Gee, I think that's caused from something." And so they did a biopsy of one of the things on his face, and sure enough, he has Britt-Hogg-Dubé syndrome. And all that is a protein abnormality that can cause you to be more susceptible to cancer, because that protein helps protect your cells from cancer. And so for lung or kidney cancer, but it can also cause spontaneous pneumothorax, so spontaneous collapsed lung, and kidney cysts that can eventually turn into cancer. And so he was the first one to be diagnosed. And so, you know, it's funny, but it's not funny. He then had to tell his family members that, hey, this is a genetic thing, and so you guys need to be tested. And a lot of them didn't want to get tested because they're like, oh yeah, we got this or whatever. But when they started looking at family history, they had aunts and cousins and people that have died. His aunt, for one, recently died from lung cancer and never smoked a day in her life. And they couldn't treat her because they didn't know what kind of cancer it was. It was an abnormal form, it wasn't a usual form of cancer. So that got them all to thinking. And then they had an uncle that died from kidney cancer, and his was really odd. And they thought maybe it had just metastasized from somewhere else because he was a smoker. And so it kind of got them all to thinking. And so then he had a cousin, and they didn't know whether it was his mother's side or his father's side. And so he had a cousin that went and got tested, and so then they knew it was the father's side and not the mother's side. And then you have a 50-50% chance of getting this, right, genetically. But all of his brothers and sisters have it, so they're 100%. And so then my daughters are in the process of getting tested. And everybody was real weirded out by it. And then I'm like, but you have something that if we screen you, so annually you're gonna get a screening through your lungs and your kidneys. My husband actually did have a cyst taken out a few years ago, and they didn't know what it was. Three different places, Mayo Clinic and a place in California and the Christian here, and nobody knew what it was. It was just this, funky thing. And so I'm like, so you're actually lucky because you don't just get screened every year for lung cancer or kidney cancer, and you wouldn't even know. And so I keep telling his family, I'm like, to know this is a blessing because they're going to screen it and they're going to remove it before it turns to cancer. So why are y'all boo-hooing? It's like, get over it. You'll be fine. So, and anyway, I can imagine, I don't like the things on my face. If I was a lady, I probably wouldn't want that either, but it doesn't have a very nice complexion, but it's a little guy. So anyway, so that was something that they could do by PCR. So if you carry a mutation, and you knew that you had that mutation, would you want to carry it on to your offspring? So do you really want to know? So in the case of his, yeah, you'd want to know because you could be proactive as far as being screened for cancer. And my youngest daughter is pregnant. Of course, she got pregnant after this, but so they're finding out whether or not she has it. But again, she's like, that's not going to keep me from having babies because it's nothing, it's not going to be like you're going to be born with a third arm or anything. We're just going to have to watch it. And it doesn't present itself until between the ages of 40 and 70. So, no problem. When I went to this lecture, and they were talking about how you could do genetic studies, one of the questions, and this was, again, about 10 years ago, and I asked on a break, I asked the guy who was giving the lecture, because he actually mentioned multiple sclerosis. And at that time, I really wasn't showing much symptoms. I wasn't walking with a cane or anything, but I knew I had it. And so I asked him, and his response to me was, well, because I said, well, should I have my daughters tested or whatever? And his answer was, well, do you really want to know? And by all means, because there's nothing you can do about it. So do you really want to know? I didn't get affected until I was almost 40, but if I'd have known when I was 20, would I want to worry about it for 20 years? So I thought, well, okay, whatever. So again, what do you want to know? But there are some people that will choose to not have children because of certain conditions. And there are people that will have babies knowing that they survived it, the kids will survive it. So my daughter knows a man and a woman who both are deaf, and both are deaf for the same reason. They have bones missing from their inner ear or something like that, and both of them have it. And so they've had 3 children, and obviously all 3 children were born without bones in their ears, so they're all deaf as well. But again, they chose to have children because, it's not horrible, because, you just do life without hearing. So anyway, again, would you want to know ahead of time? And again, that's your decision. That's what you want to do. But again, they're finding out more and more. You chose to have some of the genetic testing with yours, and my daughter said she wasn't going to have any. So again, your personal choice. They can also be used for predictive tests to find out if you're more predisposed to common disorders, things like heart disease or cancers that could arise in adulthood. Colon cancer, again, you have family history. The shedding of cancer cells in feces, I see now that they're actually showing that on TV. If you've watched it's simply as Get, Go, and Gone, or however they say it, where, in the day you had to do that whole colon prep thing where for the day before you couldn't have anything but clear liquids, and then you had to drink all that medicine or that stuff that would clean you out, and you had to go in and get a colonoscopy and all that good stuff. And now you simply order a kit. The doctor orders you a kit. It comes to your door. You collect a feces sample. You put it in the box, and you send it off, and it comes back to whether or not you have the marker for cancer. We actually are playing with this, if you will, right now at St. Elizabeth's. And so as any new methodology, you have to do correlations. You have to figure out, in your population, what have you got for positives. And so they said, ask for volunteers in the hospital, so anybody and everybody. they actually saved some bladder tissue from Hubert Humphrey, okay? They had tested him way back in 1967, and he tested negative for bladder cancer, but then he did die of bladder cancer in 1978. But again, they saved a bit of his tissue, and with PCR, they actually found out that they had determined that he had bladder cancer way back then. So from his bladder tissue and from urine samples. Then a British chemist actually donated his eyes to science, and they saved his eyes, and they were able to use PCR to show that he lacked a certain gene that made him colorblind. So again, I don't know how many body parts are going to be saving from people, but anyway, they have from was 1984. They had a person in St. Louis that had a rare disease that attacked his immune system. I remember it being big news, and lo and behold, it was HIV before HIV really was all that popular. But again, I remember them talking about his blood. Because, and never mind, I'll say that story for blood because it's really a big story and I don't want to tell you twice. Again, for forensic DNA, DNA fingerprinting, again, in the early days. So again, if you watch some of those old shows, back in the day, they didn't trust it. They didn't trust really you can take a person's spit and then you can find out who they are. And so they really didn't trust it. So back in the day, it wasn't, it's admissible in court. You couldn't use it. They really didn't trust the results. But as you do know now, more and more, they are using it because they've shown that it can prove things. And it's actually gotten people out of prison who've actually been in prison for a lot of years because they were falsely accused, and now they've gotten the DNA proof from whatever they still had and were able to go back and say, okay, never mind, you weren't the one that did it. Which again, kind of leads you to, well, what if they, with the death penalty and all that, and now we can prove they're not there and all that. So a lot of ethical questions came out of that one. So again, back in the day, we couldn't use it, but now it's a little bit more widely used, and again, to help free people who are falsely accused. So they've used PCR for ancient DNA, okay? So you know what the Dead Sea Scrolls are? Okay, so for years and years and years, they were thinking that, the dead people have come out, oh, these are the Dead Sea Scrolls. Well, they can prove, again, by taking samples from that and proving whether or not it is truly the Dead Sea Scrolls. They've used it to trace human migration. So as far as, if you knew from way back when all the land masses were like together, and then slowly over time they all separated into the continents and things like that. And so it's kind of like, this land split, and all of a sudden you were either on this continent or that continent. So again, they can kind of prove migration and going through land channels and things like that. They've taken the paint, from cave paintings like that are in New Mexico and places like that. They've actually taken some of that paint and done some DNA studies. And they found that the blood or whatever it was that they used for paint actually came from animals that were more, what's the word I'm looking for? They're like northern animals, but yeah, why are they in Mexico? So they figured that maybe it's some mythical power or something that they believed that the blood of this polar bear was going to do something when they put the paint caving, whatever. So again, religious or magical powers. They've actually used PCR to correct errors in evolution. So I remember from my textbooks back in the day, you had that picture of that little, almost like a dog, but they said it was one of the very first horses. They've actually proved that it wasn't a horse, but it was actually a descendant from a zebra. So that's kind of interesting. They also, so in Jurassic Park, right? Have y'all seen Jurassic Park? They find a mosquito, right? When the mosquito, a mosquito in the tree sap or whatever that preserved this mosquito. And they went into this mosquito and they were able to get DNA from dinosaurs because this mosquito apparently bit the dinosaur and they could recreate dinosaurs, right? That's the premise is that from Jurassic Park. I don't know, I've never really seen the movie. But anyway, but they've actually found termites that have been imprisoned in this tree sap. And what they found out is termites are termites. They've never changed in the zillions of years that they've been around, that, you know, so termites are gonna be here forever, I think, and anyway, so. But they also used, they found a woolly mammoth, an intact woolly mammoth, frozen up in Alaska or something. And this was actually a PBS special, I don't know if you saw it or not, but they literally dug up the entire woolly mammoth and, you know, used a hairdryer and blew them all off, right? And used some of the pulp from inside the bone, and they took the DNA from the woolly mammoth, and they tried to impregnate an elephant using an elephant egg, I guess. Take the DNA and tried to make a woolly mammoth. I think the first one didn't succeed. I don't know if they're still trying. But someday we might actually have a woolly mammoth walking the earth again, as they are.
Jurassic Park.
That's a true story. That's a true story.
I just saw a video that there was one, that somebody had a video of a woolly mammoth, but it was from like, I don't know, Antarctica or something. Like they weren't close to it, but it definitely doesn't look like a normal elephant.
Huh. Yeah.
And this was recent.
Huh, wow, yeah, interesting. It was an interesting video or movie simply because of all of the religious, that the Eskimos had, the, I don't know if it's really religious, more superstition, I guess, and that you had to bring the thing up in its entirety. You couldn't just like off a foot or something, you had to. And so I guess the Eskimos at one time saw the, with the global warming and stuff, the tusks apparently had melted, you know, the snow had melted enough to where they saw the tusks. And so they told somebody, and so they literally had to get the entire block of ice that had this entire woolly mammoth. It's a PBS special, you have to watch it sometime. Rising the Mammoth or something like that.
I think they were worried about decom, that's why they took the entire thing.
But it also had a lot of superstition or religious or something with the Eskimos too, I remember that. But you are right, I mean, but there was some care. But I do remember him using a hairdryer to blow the hair. I do remember that in the video. But anyway,
I watched a video in high school in biology where a horse gave birth to a deer.
a deer.
Yeah. And I think the first one didn't make it, but the others did.
I've heard of horses giving birth to zebras. That they were using that to try to, the mother, the mare was a surrogate. It was actually sperm and egg from zebras. But then they implanted that into this horse, and then this horse gave birth.
It was not
to
a
this
mix
zebra.
of a horse and a deer. It was a deer.
A deer, so
Yeah, but
somehow
were
they
using
implanted.
it was either a cow or a horse. I'm pretty sure it was a horse. And yeah, it was,
Interesting, yeah.
I don't remember, I think its name was Dottie. Maybe. Or the spots.
So, you know, they joke about a man having a baby, but in all honesty, it technically could happen.
He doesn't have the uterus that was for the son.
But there is a way, again, theoretically, you could implant the egg, and the egg could produce a placenta on some other organ. So, yeah. And I know it's out there, but they say it could be done. But anyway, it's too cool. Okay. Future of PCR, again, the equipment's about the size of a microwave oven, so it's not big, and thousands of dollars is way cheaper than a lot of these, hundreds of thousands of dollars. So they're still tinkering, still making things go along. I remember during this lecture that I went to, they were basically talking about it being like a chip size, and he equated it to, if you've ever seen episodes of Star Trek, where Bones, the doctor, has that little medical
Tricorder?
thingy, whatever, and he just waves it over Captain Kirk and says, okay, yeah, you've got a headache. You know, I mean, he was like, okay, that's what it's gonna boil down to, is we're gonna have this thing, and we're gonna be able to wander around. But if you think about it now, since then, and again, this was quite a few years ago, think of glucometers. I mean, diabetics have them in their house now, right? Think about the iStat machine that we can find out whether or not a patient's having a heart attack, you know, simply right there in the emergency room. And so it is kind of cool. It is kind of coming around. No, we're not just waving it in front of you. We're still using a sample. but it's gotten a long way. Again, chemistry analyzers, when I first started, filled this room. They were huge. And now you got little ones that'll just sit on the table. And you got your little one that you just held in your hand and tested somebody glucose. So again, it's come pretty cool. So again, heart disease right there in the doctor's office. And yes, we can do that now. Pretty cool. So some roadblocks in PCR, some things that have caused it not to move ahead. Again, patents. You get a patent for anything because you want to get a patent, right? Because you don't want somebody to steal your idea right out from under you. And then here you've done all this work and then they're going to get all the money. So again, patents are very expensive. Low volume. Is it worth it? If only 1 in 100,000 people have that disease, why should I put the effort into finding a way to diagnose it? Where if it's 1 in 10, okay, well then it would make more sense, right? So again, low volume. And again, you have to get a return on your investment. Is there money in it? Okay. So again, CAP, CLIA, Clinical Laboratory Improvement Act, and the FDA, all those take money, all those take time. A lot of loopholes that you have to go through. So some reasons why things aren't moving where they should go. A lot of it's just all about money. So that's basically your 3 steps. Again, you have your DNA, we gotta separate it, and then you got your little primer molecule, and it attaches it, and it zips up your zipper, okay, and you get, so your denaturization, your annealing, and your elongation are the copies. So it's just basically a cute little picture that I found somewhere. I don't remember if I should have noted where I had it, but anyway. And then just, again, another picture. As far as breaking your DNA apart, your little fiber molecule, as long as it zips it up, it makes your copy. You don't know it. And that's it. So, what do you need to know for the test? Oh, never mind, we'll review it. This test isn't until Monday.
Is this technically test 6?
This is, yes, this is with TDMs.
Okay.
That's Monday. Because tomorrow is your test 5. That's your blood gases. And that'll be from like 8 to 9. And then body fluids. And next Friday is the night.
Did you say
So, yes. So on Monday will be your test 6. And whatever else we have to finish up. I don't remember. Tuesday, we will review for your final, and we will review for your lab practical. And then on Friday, so we'll have to draw straws, I guess, on Monday. We're going to do some splitting recording. And we'll draw straws. Any other